A warm good morning to everyone. We are immensely pleased to invite you to attend our Saphire 2020, a virtual meet. This year, due to an ongoing pandemic, we will be conducting a live webinar. We look forward for your active participation in our webinar. Before we start this webinar, I would like to give a few instructions to the speakers and participants. All of you kindly switch off or keep your mobile in silent mode. The speakers, please note, once you log in, please mute your audio icon below your image before pressing Join Now button. Also, when your turn to present comes, please speak first for 10 seconds, and once your video starts live, only then present your presentation. There is a live chat box in the NITE YouTube. Any queries about the topic being discussed in the webinar can be put in it. It will be taken up at the end of the presentation by each speaker. So now, without much delay, let us start the webinar. Now, Professor Dr. K. Subramaniam, Head of the Department of Cardiology of KS Hegde Medical Academy, will be delivering the welcome address. Over to you, sir.
Hello. Good morning to all the physicians, the faculty speakers, colleagues, and my dear friends. It's indeed a great honor for me to welcome you all to the second edition of the Saphire 2020. On behalf of the organizing committee, I would like to express my most sincere gratitude to each and every one of you for accepting our invitation and for being a part of this unique webinar. All of us know that we are in the midst of a corona pandemic, as a result of which we are conducting this webinar on a digital platform, and we are not able to meet you personally as we had done it last year. The Saphire 2020 has been designed to provide an innovative and comprehensive overview of the structural and peripheral vascular interventions. Many distinguished cardiologists and faculties across the country have joined us today to provide rich knowledge into this very important but at least discussed arena. The aim of Saphire 2020 is to provide an informative platform wherein new insights and scientific wisdom in structural heart disease and peripheral vascular disease and its management will be provided in order to improve the outcomes of your patients, which is the final goal of this webinar. I express my sincere gratitude to my dedicated team for their untiring support in planning and arranging this meeting. We hope that you will enjoy Saphire 2020 and that your interactions with your colleagues from different prestigious institutions and various cities all over India will stimulate a creative exchange of ideas and will be personally rewarding for you. We look forward for your active participation in this webinar. Thank you.
Thank you, sir, for your kind words.
I shall also take this opportunity to brief you about a glimpse of the Saphire conference conducted last year. There were 275 delegates who had registered and attended the conference, and this gave us all the encouragement and moral support to take this conference forward even this year too. As we all know, the field of interventional cardiology has grown exponentially in the last 3 decades. It has gained all-round acceptances owing to its short and long-term proven benefits. It's important for the physician as well as the interventionist to be aware about the procedures in a cognitive and clinical perspective. Most of the practice of an interventional cardiologist is usually restricted to coronary interventional work. There are several non-coronary interventions where he can be trained and skilled to perform. So these interventions include structural heart diseases like device closures of congenital heart diseases, left atrial appendage device closures, peripheral vascular disease management, upper and lower limb vascular interventions, valvular heart disease interventions including valvuloplasties of all the 4 valves, and the newer technology which is emerging, that is the TAVR or TAVI, that is transcatheter aortic valve implantation or replacement. So where a catheter, through a catheter, a valve, aortic valve is being replaced without the patient undergoing a aortic valve replacement surgery. A carotid angioplasties, stent graft deployment for aortic aneurysms and aortic dissections, renal interventions like renal angioplasty and embolizations of pseudoaneurysms and renal AV fistulas, stenting of post-hemodialysis patients who have central venous occlusions. Although a lot of educational and training programs are held in India on coronary interventions, exclusive conferences on structural and peripheral interventions are relatively rare. Hence, Saphire has been dedicated to focus on educating the variety of non-coronary interventions. The main objectives of the conference being to accentuate the importance of the spectrum of non-coronary interventions among cardiologists and physicians, to deepen the understanding about the newer interventions like TAVI, L appendage closure, post-hemodialysis AV fistula interventions, to illustrate the knowledge on the techniques used by the expert operators in performing interventions and management of complications. So we had an excellent speakers and interventionists who were experts in this field from all over the country and who delivered very educating lectures on various aspects of peripheral interventions last year. Hope we will be able to extend our hospitality and meet you in person next year and meet all of you in person. Thank you one and all.
Yeah, they can go.
Thank you, sir, for your kind words. The next program will be the keynote delivered by Sri N. Vishal Hegde, Pro-Chancellor of Nitte deemed to be University. Sri N. Vishal Hegde is the son of the Chancellor of Nitte deemed to be University, Sri N. Vinay Hegde. Sri N. Vishal Hegde is an industrialist and academic administrator with more than 2 decades of experience in general administration. He is a management graduate specializing in marketing. He has in his world of endeavor both expertise and education. Mr. Vishal Hegde holds the position of trustee, Nitte Education Trust, which is a renowned premier educational organization in Karnataka, managing over 30 institutions in 3 campuses at Mangalore, Nitte, and Bangalore. With a student base of over 25,000, they include medical, dental, engineering, management, allied health sciences, hospitality and technical, liberal educational institutions, a host of schools, and a large multi-speciality hospital. He is also the director of Lamina Group of Companies, which is engaged in the manufacture and export of automobiles, leaf springs, and brake drums. He has widely traveled in India and abroad. He is currently the Pro-Chancellor of Nitte deemed to be University with the responsibility for financial administration, procurement management, and global initiatives of the university. Now the recorded message by our Pro-Chancellor will be played.
Of Saphire 2020. Despite the difficulties we've all faced due to the COVID-19 pandemic, the organizers of this event have kept up the tradition of having this conference even this year. Technology has helped us in connecting with the outside world, and I congratulate the organizers for arranging this conference. Medical profession has been in the forefront of fighting the COVID-19 pandemic, helping the government in tackling the medical difficulties faced by the public at large. Nitte University has contributed its bit through the Justice K.S. Hegde Charitable Hospital in fighting this pandemic. For a young university like ours, it has been a learning experience. I'm very proud by the way our colleagues have risen to the challenge and have been delivering good quality healthcare. Cardiology has emerged as a key area in the medical profession. With the use of technology, the treatment methods have seen a sea change over a period of time. The treatment methods now have enabled patients to have a better quality of life. Conferences like this, I'm sure, will go a long way in helping young budding cardiologists keep themselves abreast with the latest technology and latest treatment methods. I'm sure all the cardiologists who are participating in this conference will benefit from the vast experience that the speakers who have been drawn from the top cardiology institutions of our country and around the world will give them the time and the patient hearing to learn from this experience. I wish this conference all the very best, and I'm sure in years to come, we as Nite University will have an opportunity to welcome all you participants to be with us in our campus in 2021, when I'm sure this global pandemic will go away. I once again like to thank the organizers for having given me an opportunity to be with you all and participate in this program. All the best, and I'm sure all of you all will have a great learning experience. Thank you, ladies and gentlemen.
Thank you, sir, for your kind words. Now we will move on to the scientific program. Our first speaker that we have is Dr. Sanjay Mehrotra.
Good morning to all of you. Can you hear me?
Sanjay Mehrotra is a senior consultant in cardiology working at Narayana Hridayalaya at Bangalore. He has experience of working in top hospitals in USA and UK. He has multiple publications, abstracts, review articles in both national and international journals. He's a member of Cardiovascular Society of India, British Cardiovascular Interventional Society, proctor in endovascular treatment of aortic stent grafting, and specializes in carotid interventions. He will be presenting on the topic current status of transcatheter aortic valve implantation. Over to you, sir.
Good morning to all of you. Can you hear me, please? Are you able to hear my slides, please? Are you able to hear me?
Yes, sir. We are able to hear you.
And can you see my slide deck?
I'm not able to hear the slides. We are able to see your video.
What about my slide deck? Can you see the slide deck?
No, we are not able to see.
Okay, let me see.
Give the instructions. Slide. Okay. All right.
You appear to come share. Suddenly we may have to help here. Put up the video. Okay, can you see it now?
Yes. Yeah, now we are able to see, sir.
All right. So good morning to all of you. Thank you very much, Dr. Subramaniam, for inviting me to deliver a talk on the current status of TAVI. And I wish you a grand success in this conference, Saphire, which you have been doing for some time. I will be talking about the current status of the transaortic valve implantation. As you know, that severe aortic stenosis has a very significant unmet need. The prevalence of severe aortic stenosis is about 4 to 5% in people who are more than 75 years of age. And more than 30% of all symptomatic severe aortic stenosis are not offered surgery. Inoperable and high-risk patients are very difficult to treat. As you all know that we have normal aortic valve area, which is about 3 to 4 square centimeters. In patients who have mild aortic stenosis, the valve area is usually more than 1.5 square centimeters, but we call it severe if the valve area is less than 1 square centimeters, and in between 1 and 1.5 square centimeter valve area we call moderate aortic valve stenosis. Now, who needs treatment? All patients who have severe calcific aortic stenosis with reduced systolic motion of the aortic valve, patients who have mean gradient, which is more than 40 millimeters of mercury, or a jet velocity on echocardiogram, which is more than 4 meters per second, and of course the aortic valve area, which has to be less than 1 square centimeter, or indexed orifice area in relation to body surface area, which should be 0.5 centimeters square per meter square. In patients who have left ventricular dysfunction, this criteria have to be assessed or seen after a dobutamine stress test. We all thank Dr. Alain Cribier, who is a French, who in 1994 made the first sketches describing the possibility of a permanent percutaneous aortic valve. And the first implant was done in year 2002 by using a percutaneous method. And mind you, this was a transatrial implantation. So we have our salutations to this man who discovered this technology, which is grown leaps and bounds, and we are witnessing a revolution in technology. More than 300,000 TAVRs are done globally, and it has proven its lower mortality nor inferiority as compared to surgery in extreme, high risk, intermediate, and low risk patients. The global trends of this technology, the FDA approved the usage of transaortic valve replacement in 2011 in patients who were deemed inoperable. In 2012, this indication was expanded to high risk patients when you compare it with the surgical aortic valve replacement, we call it SAVR. In 2016, TAVR was again approved for intermediate risk, where it proved its non-inferiority and some superiority, and the approval was granted to both Sapiens XT initially in the intermediate risk patients, and over a period of time it was extended to the self-expanding valves as well. In 2019, which is last year, TAVR was also, TAVR proved its non-inferiority and superiority to surgical aortic valve replacement, and FDA approved the usage of Evolut and Sapien 3 in lower risk patients as well. Now, how the TAVR has evolved in India. The first TAVR in India was done in February 2011. Core valve and Evolut were approved since August 2016. Sapien 3, which is the Edward valve, was approved in 2016 November. My valve, which is an Indian valve, was launched in December 2018. And the TAVI implants have been growing in India significantly, especially in 2019. The data I have for 2020, but we still are not presenting that because this year the implantation probably have been less because of the pandemic, where at least for 3 months, the number of cases performed all over the country were extremely low. Currently, there are more than 75 centers who are performing TAVR, and more than 95% cases are done using transfemoral route. About 3% are done using transsubclavian, and 1% direct aortic. Now, here I present a case who is a 79-year-old gentleman in cardiac failure who has severely congested cardiac output state. We tried medical stabilization with inotrope. This patient had significant, this patient had significant failure symptoms. His neck veins are completely engorged. He could not lie down flat. We tried to stabilize for a long time, but it did not work. So ultimately, we took this patient for a CT because the CT is the most important tool for doing and planning the procedure. But unfortunately, while he was in the CT room, arrested, intubated, and taken directly for a life-saving balloon aortic procedure. By this time, you see the valve, the wire across the aortic valve, and we are opening with the balloon. By doing this, the patient actually improved significantly, and then subsequently, about a week later, we planned a TAVR for this patient. These are some of the measurements which are done using the 3 Mencio, which is provided by the company. Here, we planned an evolute valve, and the important measurements which we do is the size of the annulus, the size of the height of the coronary tree, the size of the femoral artery, because these are the important measurements, and I'm not going to go into the details of these things. Now here we are trying to cross the valve. The pigtail catheter has been positioned in the non-coronary sinus, and you see the valve, the wire crossing. This second picture shows looking at the valve which is outside the body just to see its loading. And here we look for the correct loading of the valve, and there are certain criteria which we use in deciding that. And now the valve has been positioned. There is a ring below which the valve is, and the right non-coronary sinus pigtail catheter becomes your marker. So we start deploying the valve just below this right coronary pigtail lower end, and you gradually open the valve. This is a recapturable valve. And here you see we are about 3 to 4 millimeter on the right non-coronary cusp and a bit deeper on the left side, but then the valve is not completely deployed, but you see a bit of constraint, and there is some calcium on the left-hand side. We did do a post-balloon dilatation for this patient, and this patient improved significantly post-procedure. There was probably about 2 or 3 millimeters of gradient. Now, all these procedures nowadays are done using ProGlide pre-closure devices, but it is very, very important that you look at the femoral flow after the procedure. Your procedure is not done until you have seen a good flowing femoral artery to the lower limb. If you don't do that, the most common cause of complications in TAVR program are the groin-related complications. Now, I will show you one more case, which is a case with a difficult access. He is a 74-year-old gentleman who underwent a coronary bypass surgery 10 years ago, but now is in congestive cardiac failure. Unfortunately, most of our patients wait too long after they go into, and we have to sort of many times do procedure when they are already in failure, which increases the risk. So I would recommend that if you find significant aortic stenosis, you should start prompting them to go for an earlier procedure rather than waiting for them to go into heart failure. Because once they go into the heart failure, it is very easy for the family to decide that there is no way now and we have to get this done. But I think it becomes difficult for our clinicians to treat these patients because the complication risk and the risk of the procedure goes up. Similarly, this patient is now in congestive cardiac failure due to left ventricular failure, and she's got severe aortic stenosis. We could stabilize him, but he was not able to lie down. And he still had orthopnea and PND. And this is his anatomy. He's got calcium all over his aorta. He's got an occluded right common iliac artery. And he's got a kind of a stenosis, which is like a quiet clot just below the arch level, where we were worried that whether we will be able to go inside through the transfemoral route. We try to look at, this is the femoral injection, and you see there is a tight stenosis. He also has got a lima coming out of his left subclavian artery. His carotids are significantly diseased. So where to go from? And we all feel that transfemoral axis is the best axis. So ultimately, we decided that we are not going to take a chance going from left subclavian, and because of diseased coronary carotid artery, it becomes a contraindication for an alternative axis using carotid artery. So we wired both the femoral arteries and dilated the peripheral vascular tree and implanted stents for us to create a passage. Although sometime probably we could have done the implantation of the stent a bit later, but it was not, there was so much of recoil that we were worried that unless we deploy a stent, this artery is not going to give a tracking to our device. And once we opened this, then we went from the transfemoral route. Here there is a Amplatz catheter which is in the left ventricle, and now we are doing a balloon aortic dilatation, which is what we call as pre-dilatation, using pacing. And pacing is always done while balloon dilatation, and there is some AR created. Then this is a this is a balloon expendable valve, and you see we had a problem that the left coronary ostium is very, very low. The height of the left coronary ostium was only about 8 millimeter. Our limit is that it should not be below 10. 12, more than 12 is the ideal. 10 to 12 is probably okay, but this one was almost 8. So we had to protect, and this, of course, was a post-CABG patient, so the lima was protected, but we had to protect the left main to the circumflex flow, and we have got a guide catheter. You cannot do this later. We have got a guide catheter inside the left coronary ostium, and there is a Edward sapien valve which is sitting next to it, and we have got a stent which is positioned in the left circumflex artery. Now you will see we are pacing and expanding the valve, and this is done very slowly over a certain period of time, and you sustain that injection, that inflation for a certain time. And now you see that, and now you check for the flow, if there is adequate flow in the coronary tree or not. Now when you see, you find that there is probably some reduction in the flow in the left subclavian artery, and we were not able to understand why did this happen. If you see, I have advanced that stent distally, but after seeing this, there was a suspicion that there is a dissection, and we will not be able to cover this dissection with the stent which I have initially planned. Mind you, this stent was not meant for doing an intervention on the left subclavian artery. This stent is positioned in the left circumflex artery for a left main occlusion. If it happens, you deployed a stent which protrudes inside the left main a bit for the left main to not occlude and create, although this patient had a protected left main. But if suppose left main gets occluded and you do not reperfuse the left main, the person will die within the next 3 to 5 minutes. Now you can see that we could exchange that stent with a longer stent because of the presence of a sapien valve. If you have an evolute here, it might be a bit difficult to advance a stent. The sapien is probably a bit more easier to cannulate a left coronary artery despite its presence being there. Then now this is the stented left circumflex artery with a sapien valve sitting inside the aorta. There is a bit of leak. If you wait for some time, this leak usually disappears, and this patient probably had no leak at all. Now, finally, we had to post-dilate when we took the device out by doing a kissing balloon dilatation of the aortic bifurcation at the level of the common iliacs. Now, I will show you one more patient who was an alternative access for transaortic valve implantation. She's an 88-year-old, he's an 88-year-old male, diabetic hypertensive, again status post-coronary bypass surgery. He had dyspnea of class 3 since 1 year and angina for the last 1 year. His echo showed severe aortic stenosis with impaired LV functions, EF being only 25%, and his gradient across the aortic valve was only 44, but in presence of a low ejection fraction, that becomes important. This is the planning. It showed both iliacs were occluded. There was a patent lima, and we were worried about how to go for this because we have the only access we had because he had also had carotid artery disease. The only access he had was left subclavian artery, which has a stent, which has a lima coming out of it. This is occluded iliacs, and there is you see the left subclavian here. Now, what we do here, that the surgical exposure of the left subclavian artery is done. There is a conduit connected to the left subclavian artery, and we will access this through this conduit, the device. So you see the device is now being inserted through that conduit into the left subclavian artery. And we just want to see our lima position, that lima is actually supplying the left, is a grafted vessel. And here, I think I have used a portico balloon. So there was a pre-dilatation done of the aortic valve, which I think is very important because you don't want any trouble in this patient. And here, the valve, loaded valve, is being advanced and how comfortably goes across the left subclavian artery. Mind you, we do not insert the sheath through which the valve is advanced too much inside the left subclavian artery. It can be just left at the mouth of the left subclavian artery so that you are not going to cause trauma to the left subclavian artery. Now then you deploy the valve, and this is a portico valve, which is again a self-expanding valve, and this procedure was done successfully. Now these are the various kinds of valve which are available. This is Evolute R, this is the Sapien 3, this is the My valve, and this is of course the portico valve. I use almost all of them, and I choose my cases depending upon what I find is more suitable and what will give me the best result. What is the size of the femoral artery, because certain valve have better profile of their inserting sheath. So if the femoral artery is very, very small, then I choose a valve which has got the least size of the axis. Now, when you compare the durability of the TAVR with surgical valve, we have a data of 6 years outcome of Notion trial, which proved superiority of the TAVR as compared to surgical valve. When you also looked at the durability, it probably is doing as good as a surgical valve, and in certain situations is doing even better than that. Now, the transcatheter aortic valve replacement of the balloon expandable valve in low-risk patient, this was the PARTNER 3 trial, where they randomized 1,000 patients with severe aortic stenosis who were at low risk of death with surgery. They were assigned to undergo transcatheter aortic valve replacement with a balloon expandable valve or a surgical aortic valve replacement. This was, of course, a Sapien valve. At 1 year, the rate of death, stroke, or rehospitalization was significantly lower in the TAVR group. And this is, of course, the comparison of the SAVR and TAVR in various categories. I'm not going to talk too much about it. And they found that the functional quality of life at 30 days as well as at 1 year was much better with TAVR as compared to surgical aortic valve replacement. Now, coming to what are the main challenges in India, which we are going through, and I think probably we'll get over that. TAVR requires a longer learning curve and developing a process of teamwork where a surgeon are a very, very important part of your team. So it is very necessary that when you develop this team, the surgeon has to be your colleague and friend available for you if there is a problem, and you will get into a problem. It is impossible that you will not get into a problem. We all have learned from the complications which we go through. Affordability, of course, is a very important and a definite challenge. Indigenous devices, of course, they are cheaper. If they become even more cheaper, you will be doing a lot of TAVRs in this country. And of course, the cath lab readiness for a technique which is organized teamwork doing larger volumes would remain limited to few of them. You need to develop a team which will be able to handle larger volumes, because once in a while doing TAVR is not going to teach you this procedure very well. The issues which are especially important for India, cost, which I said is not, because before the procedure, but even after the procedure, the cost is important. When you lose a patient, I lost a patient and where we could not even open a valve, and the patient family said that you have to give me my money back and the valve cost, because the valve was open, and once the valve is open, you cannot return the valve. So one has to be prepared for such eventualities. And it is very, very important that we do a proper teaching and education of the family as well as the patient before doing this procedure. You should spend a lot of time. A lot of patients think it is just like any other angioplasty, but it is not. So the consent taking and education of the family is very, very important. Families sometimes may have unrealistic expectation of a TAVI procedure, considering it low risk and it's like a coronary intervention, but it is not. So you should always discuss all the risks, which are vascular risks, which are risk of stroke, which are the risk of requiring a pacemaker, which are the risk of causing a distal embolization, and also last but not least, the risk of dying. And you have to be very, very sure about it, that you tell it to their family members, get a written consent. I usually get a separate consent signed for this. And you also should say that this has been discussed with our surgical team as well, if there is a need for that. So what is the future of TAVR in India? In the US, there are about 1,400 cath labs and 400 centers performing TAVR. In India, there are about 1,700 cath labs and approximately 200 centers will be performing TAVR by the year 2025. By the year 2025, TAVR numbers in India will overtake surgical tissue valves in the aortic position, and we would be doing approximately 4,000 TAVR cases per year. This is my last slide. I will stop my presentation and I will take questions from the audience.
Good morning, sir. It was an excellent demonstration of everything in one case. It was actually a visual treat for all of us to hear from the master. It was wonderful. I think one point what I liked about the presentation is even for every junior cardiologist or anyone, that one message you gave it very clearly, that you should plan the procedure very well. That's very important. I think the most important aspect is that in one of the cases, you demonstrated what an interventional cardiologist can do. You started with stenting an iliac artery. Then you expected a complication in the coronary arteries. So you stented the coronary arteries, and subsequently, once the patient was fully stabilized, then you took up the patient for the TAVR procedure. I think it was a wonderful demonstration of how we can plan it and how we should do it to get an optimal result. That was excellent. I have few questions in my mind, sir. I think few questions have started coming. My question is, how do we select to stop sharing the screen? Sir, one instruction from the IT team. I think you have to stop sharing. Yeah. All right. So one question I have in my mind, like, how do you select whether you want to go for a balloon expandable valve or a self-expandable valve? I think this is a question. I think this is a tricky question. I do understand.
So I think although it has come over a period of time, to begin with, I think you should excel in one valve. This is my advice. And if you start using, self-expanding valve, would be a good idea that you use a self-expanding valve. In a patient where bicuspid valve is there, there is a smaller femoral size where I can put a 14 French, because the evolute is only 14 French, especially ladies. And I don't want so I did a case just about 3 weeks ago where the patient is in heart failure for the last 10 years. And she's got a valve which is diseased. She's got a huge LA thrombus. She's not stroked. She just can't lie down. Somehow we could, empty the fluid compartment. We can remove the water using a dobutamine along with some diuretic, and the patient was able to lie down for about half an hour. Now, the advantage of the balloon expandable valve is it can be very, very quick. You can finish a procedure in 15 minutes. And you don't need to many times pre-dilate the patient. So when you go with an idea that I'm just going to go inside, cross the valve, pace the heart, put the valve, I don't want any time taken for my patient not being tolerated, because these sick patients do not tolerate any episode of hypertension. I go there and 15 minutes, I finish the procedure. And that advantage is in such patients, you will save the life of the patient. And that patient walked out of the hospital. So there is certain advantages. For example, a small femoral artery, I will go with the lowest possible profile, and I find that the Evolute has the lowest possible profile. With the inline sheath, you can go with even a 5.5 vessel. So females, small size, I'll go for that. When I want to do a quick procedure, sometime when you start deploying a self-expanding valve, the self-expanding is not good. You need to retrieve and deploy again. It takes a bit of a time sometime, although you can do it very quickly. But it is important. So I choose my cases, but both the valves are very good. And there is no difference in terms of their efficacy. But my thinking is that, and also my recommendation is that you should learn one valve at a time. Once you have become good in one valve, then only move to a second valve. But you should know both the valves pretty good if you're a operator who does a lot of towers. So you should be able to do both valves. And so I choose my cases depending upon all these criteria. And of course, the cost many times. My valve is a balloon expandable valve, which is a lower cost. So when I feel that, no, this patient is not going to afford the US-based company's valve, I put in my valve, and it's the cheapest in terms of its cost. But that is a balloon expandable valve. So I have to use both self-expanding and balloon expandable. Medtronic also has come up with lower cost now, especially with the Evolute R, although the Pro is still very expensive. Edward is a very good valve. I have learned balloon expandable valve using Edward valve. That makes me, even better at the my valve. And my valve is a good valve. It's a reasonable valve.
Excellent, sir. So as we know that the TAVR is been based on this disruptive technology that we place a valve over an underlying valve, and then the native valve is crushed, and then we place this valve. And initially when these TAVR procedures were done, there was a concern about these paravalvular leaks and presence of patients developing heart blocks, developing a pacemaker, need of a permanent pacemakers, then some risk of ischemic stroke because of the embolization, as well as some vascular complications. I think most of the patients what we take is all older patients, 70 years, 80 years. I think you have shown one patient of 88 years. I think it was a very tough case, I do believe. Yeah. And in one of the cases, you also demonstrated that sometimes when you are not able to do through the femoral axis, we have to go through the subclavian axis. I think that was a wonderful demonstration of the need of a surgeon also during the procedure. Right. Can you comment on more about these things? Did you have any of these cases developing paravalvular leaks, and how were you able to manage these patients, or any patients requiring pacemakers or some stroke-like episodes?
So the incidence of paravalvular leak has come down because of a better technology of the valve, especially both the balloon expandable valve, which is the my valve, as well as the Sapien valve, come with the outskirts sheath, which takes care of the your paravalvular leak. If there is a mild paravalvular leak, it is acceptable, but more than mild is definitely not acceptable. So when we find there is a paravalvular leak which has to be treated, we post-dilate and take care of the paravalve. You have to leave the patient out of the room with no significant paravalvular leak. So the valve technology is improving by their design, so that the paravalvular leak has come down. Now the Evolute Pro also has come with a sheath around, so the paravalvular leak incidence will come down. Now, second question: what is your take on the need for a permanent pacemaker? The requirement of a permanent pacemaker is high with the self-expanding balloons. But we have now become smarter, that we deploy it very, very high. We keep the depth, and there are some new technology and new understanding coming, like the cuspal overlap, and deploying as high as possible. Especially a bicuspid valve, we can deploy the valve very, very high. So when you go with a valve which is not very deep into the LVOT, your risk of complete heart block will be less. But you will go through it. We have done nearing about 110 cases, and I have used pacemaker in about 3 or 4 patients only.
Yes, very good.
3 to 4%. And I have still not used, I have used one pacemaker for a balloon expandable valve. So the risk of balloon expandable valve causing pacemaker is very, very low. The third, complication, this is the vascular complication. I think that is the most common, and I have gone through a lot of problems with that. We had to call the surgeon because sometimes the ProGlide will not work and your artery will continue to bleed. And sometimes the artery will occlude. So you need to become a peripheral interventionist. And we are all peripheral interventionists anyway. We can sort it out within 5 minutes. Come from the other side. Many times we lead a protected wire from the contralateral side, and you can get the access, put a stent quickly, and come out of it. But yes, your vascular team is usually ready. Our vascular surgeon is mostly ready, and if there is a problem, I don't, call him now. I say, I have a problem. Saurabh, come and deal with this, and they can deal with it without much concern. Of course, it takes a bit of a time. When there is a ProGlide bleeding, life is not very easy. But we can put a contralateral balloon, obstruct the vessel, and the job can be done quickly. So all these complications are very important. You will lose a patient. If you are doing large number of cases, the statistics will catch up. And that is why I feel that prior education of the patient's family is extremely important. There may be a position where somebody walks into the lab and then he comes out dead. So we have to take it very, very seriously and educating the people. Now we have become quicker in doing the job. The whole process of communication has improved significantly. It takes a bit of time for us to also to communicate, how to communicate the family. Sometimes I usually spend about 45 minutes to 1 hour with the patient family, at least 2 to 3 days before the procedure in educating the family. And that's very, very important.
You have told the second important message to us that communication with the patient's attendants are very important. I think even the second important message to us, along with that, the planning of the procedure. So I have few more questions in my mind. Like you mentioned about the use of TAVR in bicuspid aortic valve for patients. I have seen still, I think all of us in the learning curve about the use of this TAVR in patients with bicuspid aortic valve. And the second thing is the same thing in continuation. Is there some case reports are there where they have used in patients with AS with AR, aortic regurgitation? Usually it is not done. So what is your opinion about it?
So if you are doing TAVR in India, 40% of your patients will have bicuspid aortic valve. So although it's an off-label use in the description about the valve brochure, but then in India you have to do it. So, and we are very comfortable doing it. We have learned from others about how to position this valve. Bicuspid aortic valve is not a problem. There is enough data to suggest that bicuspid aortic valve and the tricuspid aortic valve post-procedure, both the valves behave similarly as far as the device is concerned. So the only thing is that you have to implant the valve a bit higher. So in a self-expanding valve, we would like to keep the depth of the valve to either 1 to 3 or 1 to 5 maximum. So you can be at even 0 at the anal level, because the bicuspid valve opens higher than the annulus. You have a liberty to go up, and that will reduce the risk of complete heart blocks and complications. And of course, the gradings would be less. The second question about
Aortic regurgitation.
So that is not a problem at all. The only problem where you will have to worry about if you are doing aortic treatment of aortic valve disease, which has got isolated AR.
Yeah, I was meaning that.
Difficult because there's nothing to hold. If you have any amount of calcium, it is okay to do it. But I have done at least moderate AR in many patients, which is not a concern at all. Even a significant AR with aortic stenosis is no issue. But isolated AR where there is a ring dilatation, it's very challenging. And of course, there they use the self-expanding valve because you can retrieve, position, retrieve, position, retrieve. You'll have to have multiple goes when you use aortic regurgitation, isolated aortic regurgitation with no stenosis at all. But that experience is very, very small and is usually not recommended at this moment. But associated ASAR, no issues at all.
No issues. Yeah. Pure AR is an issue. I think very few operators suggest the use of TAVI in patients with pure AR. Probably because of the absence of calcium. That could be important.
There is a device coming which would be used for pure AR cases also. They will have anchoring things.
All right. One more concern is about the development of strokes in these older patients, because the whole of one of the cases what even you demonstrated showed that it was like a porcelain aorta. Whole aorta was fully calcified. I don't know how you are able to take this such a difficult valve over this heavily calcified aorta. So there is always a risk of these calcium getting embolized to the carotid arteries. So have you ever used the use of a bilateral distal protection device in these patients? Do you feel it is recommended to use in order to prevent stroke?
See, there is a slight advantage in our country that our patients are slightly younger than the European patients. I went to Copenhagen to observe once, at least 4 years ago. They had three TAVR on that day. One lady was 96, second lady was 95, and the third lady was 89. So when you go towards 90, there is aorta is much more disease. Now, but you can see presence of loose tissues inside their or calcium inside their ascending aorta. And I would say that the time is approaching where we also have to use, I have not used it, but the device has come. It is very expensive. It's about 7 lakhs cost of the device itself. So it adds to the cost. But I think if we have to do it, we can put from the radial roots maybe 2 filters, both sides, and protect ourselves from stroke. I have had out of 100 approximately patients, about 3 patients with minor stroke, but so far no major stroke. But yes, we do tell patients there is a 2 to 3% risk of stroke before we do this procedure. Fortunately, we have had just monoparesis, which lasted for 2 days and 3 days and went away. But so far, we've been lucky that no major stroke, limiting stroke has not happened. But it will happen.
Fantastic, sir. I should really congratulate you for giving such a good result. Sir, I have one more question in my mind. Like in some of the like presentations I had seen, like the valve getting like embolized and they had to deploy it in some other place. And in one of the presentations, very good operator, like he was bold enough to say that these are all the complications that happened. Like in one of the cases, he had to deploy valve inside another valve in valve kind of thing. And in one more person I saw, like Dr. Sai Satish, he was telling about a septal bulge, which was slowly pushing the valve and then pushing it out in one of the presentations I saw. Have you come across these type of complications like while doing TAVR?
Yes. So I've had one pop out. It's called as a pop out. When the valve just so one pop out in one of my senior colleagues' aunt on the table, and he's watching from behind. So the valve comes out, and the usual recommendation that it pops out. See, the balloon expandable valve is one time go. It's actually pretty decent in terms of it'll stay there. It will not come out. If your sizing is correct, there is calcium. Now, when the valve pops out, you need to pull this valve away from the ascending aorta. Because many times, if you deploy a valve in valve, there is a problem. It can occlude the coronary. So you have to snare the valve away from the aorta and deploy somewhere. If it is possible to bring it to descending aorta, okay. But many times it's not. Otherwise, you have to deploy a bit higher or keep it pulled up. You just keep it pulled up. So we, pulled it up and brought the other valve and deployed the valve, and the patient is still alive. This was done in, I would say, 2014. It's been 6 years and the patient is still alive and she's fine. And she's got 2 valves. One is sitting in the ascending aorta and one is sitting below that. But pop out is not uncommon, but you have to know how to deal with it. If the valve is not sitting inside your position, the only thing which you need to do is, if there is a significant AI, which is you have caused because of the pre-dilatation, you have to bring the second valve quickly if the patient is hemodynamically compromised. Otherwise, you can leave that valve anywhere and then should not be a problem. But yes, pop out is a problem. We do talk about it, that you need to tell the patient that if this pops out, we have a spare valve which we will put. So all these things are discussed to the patient, because these patients are educated patients. They may say, why did you not tell that this patient can have a surgical requirement? So we tell them that we usually do it in the hybrid lab, although it can be done in other places also. And the surgeon is backing you if there is a complication where a surgeon has to go in. We take a consent for a surgical operative procedure also in the same patient. So that is also important, that your surgical colleague is your friend.
True, sir. We have two surgical colleagues with us, Dr. Gopal Krishnan as well as Dr. Naresh Hegde. Dr. Gopal Krishnan and Naresh, do you have any questions about the superiority of TAVR versus SAVR? Or if you have any questions in your mind, can you please come forward, sir?
Good morning, sir.
Right?
Sorry that I could log in only a bit later, so I didn't hear the early part of your talk. Anyway, it's a very good talk, sir. So I want to know, sir, how many cases required a surgical conversion in your whole experience?
So one patient required a surgical conversion, two patients required surgical conversion. One developed a severe ascending aortic dissection, and I sort of cursed myself that I should have just gone, put in a valve, and had a backup stent ready to just take care of the dissection, or the dissection could have been taken care of later. This was one of the initial experiences. A proctor was there, and the proctor also got panicked. He didn't understand what to do. And I think I was better equipped in dealing with dissection than he was. And my worry was that a type A dissection, if you develop, then the treatment of choice is surgery. So we had to send the patient for surgery to take care of the ascending aortic replacement, the aortic valve replacement. That patient died post surgery. And the second patient we sent for surgery after deployment, the valve pops out in the evening, and the patient develops a severe AR. And the surgical colleague said that we will take care of it. The patient went for surgery, again died after about a week post surgery. So two conversions, one immediate on the same day, one after a week, and both died.
Okay.
And our center is a famous center for doing ascending aortic replacement.
Yeah, I know, sir.
But still, you would get into trouble. So, initially it used to be in the last 6 months, my anxiety about doing TAVR has come down. Otherwise, it's a very, you need to go through a lot of just speaking to the family, going through the procedure. But now we have become a bit more stable in terms of our integrity while doing the procedure.
Sir, just one more question, sir. Sir, when we do the surgical SAVR, we see such a large amount of calcium, such a
Yeah.
very heavy calcium, and we have to debride the whole calcium. I just want to know whether you have, I was not there for the initial part of your talk. Is there any scoring system by which you avoid a heavily calcified valve? No.
No, we want
No.
calcium.
Yeah,
If
yeah.
we don't have
No.
calcium, we have a problem.
Yeah, right.
The only
Okay.
thing is that if there is an annular calcium or a LVOT calcium,
Okay.
if there is an annular calcium which is sitting in one chunk on one side, and
Okay.
and I would recommend you also that start seeing your CTs of patients who are undergoing your replacement, because your learning becomes very, very good. When you see the anatomy of the patients looking at the CT, you know where is the calcium, how would this calcium behave, and a surgeon's mind will start working differently when he sees on the table as well as
Okay.
he sees on the CT. So I would recommend start seeing all your CTs of your all aortic stenosis patients, and don't mind going into deploying the valve also, because a lot of surgeons in the US have started doing this. Although
Okay.
that will take away some work from us, but I think surgeons will come forward and start doing this work. The second thing is we do need calcium, but when there is an eccentric calcium, we usually avoid putting a balloon expandable valve because it can rupture the aorta. There I will choose a self-expanding valve, which would be helping. So calcium is not a problem. At 90, you will have a lot of calcium. Calcium is no concern at all. The oldest we have done is a 90-year-old fellow, and he's alive.
Fantastic. So have you done any cases with the transapical route with the surgeon?
No, not we chose about it. This case which I showed you, which had no access at all with a lima going, we thought transapical. The transapical has been abandoned all over the world actually, because the mortality is pretty high and the complication rates are very high. So no, I have not done anything transapical. So if at all, we will go transcable.
Okay.
And do it if we don't have access. So you can go transcable. You can puncture the cavity, inferior vena cava, go into the aorta, and go and deploy. Trans-aortic is good, and we did decide to do a trans-aortic, but we didn't need it. The case which I showed you, where there was a concern when I put the subclavian catheter, the lima will occlude because the device will take but then the measurement of subclavian was 6.5 and the lima was flowing. So we went ahead and deployed through left subclavian.
I think we don't have any questions there. We have answered all of our questions in a very nice way, and we have sorted out all the issues, whatever complications, the way how to manage, how to plan. I think you have given a very important message. One is the planning of the procedure, and second thing is about conversing with the patient's attendants. I think two important messages for us. TAVR is going to come up a very good way in India in the coming years. As we're hoping that many centers would definitely would be doing these procedures in the future also. Thank you very much, sir, for your very illuminative talk. Thank you for being with us.
I enjoyed it. Thank you very much, and I wish you all the success in today's meeting. And I may not be able to attend that because I have some other obligations today, but it was a wonderful session interacting and answering the question. Thank you so much.
Thank you very much.
Yes, spoken by Lynn.
Thank you, sir. Next, we have Dr. J. Eridan.
Good morning to all. Can I start sharing my screen? Oh, okay. Carry on.
He's a senior consultant in cardiology, currently working as the director of peripheral vascular interventions at Madras Medical Mission, Chennai. His special area of interest is interventions for aortic syndromes. He has got 34 publications and 72 presentations in national and international conferences. He will be presenting on the topic Management of Complications of Endovascular Stent Graft Placements in Thoracic and Abdominal Aortic Aneurysms. Over to you, sir.
Thank you. Thank you for the kind introduction.
Good morning, Dr. Elilan.
Good morning, Subramaniam. Hope everything is going well.
Am I audible now?
Yeah.
Yeah, Dr. Elilan, good morning and welcome to our Saphire 2020. We are very lucky to have you this year too. Last year you gave such a very educative talk, very illuminative talk on aortic stent grafts as well as aortic dissections. We are very glad that you have also joined us this time also to discuss about the various aspects of the complications as well as the follow-up of these patients of these EVARs and TVARs.
Thank you, Dr. Subramaniam, for inviting me every year. Are my slides visible?
Not yet. Not yet. Please, can you please share the slide, sir? Oh. Yeah.
My screen, my slides are seen?
Yeah, your slides are seen. Your slides are seen very well.
Yes. Okay, thank you, Dr. Subramaniam, for inviting me year after year. And two things that I learned at Escorts is one is intervention, the other is friendship with you, and hope it blooms in the future. So thank you for inviting me. Today I'll just show three cases where we had complications following TVAR and then how to manage them. TVAR, we know, is a procedure where by endovascular approach, you are closing a thoracic aortic aneurysm. So this is how it is done. Looks very simple. You pass a guide wire, you pass the stent graft, and then deploy the stent graft and come out. This is basically the procedure. But you can have a lot of complications. One is it could be stent graft migration. You deploy it at a place, later on it slips down. You could get graft infection. You could have ischemic strokes. The scraping of the aorta by the device can cause ischemic stroke. myocardial infarction. Patients are usually elderly, all above 70 plus, and they might have atheroma in the aorta, which can get dislodged, or they might have coronary artery disease, which might be compromised while doing the procedure. You can develop endoleaks. There are 5 types of endoleaks. We won't go into the detail. Then spinal cord ischemia, especially if you are covering a long segment of the thorax. When you are covering more than 200 millimeter of the thorax and you are covering up the artery of Adam-Kivix, then the chances of spinal cord ischemia is high. Then you can get retrograde dissection of the aorta. These are the common complications seen. So let us see case number 1. This was a 63-year-old male, a systemic hypertension patient, presented to the emergency with acute chest pain and breathlessness of 6 hours duration. Hemodynamics were borderline. He was admitted around night 3 o'clock. His pressures were 170. He was profusely sweating. He was in shock. So we did an urgent CT. The CT chest showed aneurysm of the descending thoracic aorta, Stanford's type B aortic dissection after the left subclavian, and there was a contained rupture into the pleural cavity with a large hemothorax. So with these complications, he landed to us. Now, rupture is a fatal complication. Almost 90% they don't make it out. So it is an emergency. So we immediately informed the Medtronics people that we need devices. We told them the sizes, and luckily by another 2 hours they were able to give us the device. So patient who got admitted 3, somehow with ionotropes and blood transfusion we could maintain some stable hemodynamics till 7 o'clock, and then in the morning 7 o'clock we started the procedure. This is his X-ray chest showing large left-sided hemothorax. Now what do? Should you do an ICD for the hemothorax and then do the endovascular repair of the aorta, or you should do an endovascular repair followed by an ICD? Now, doing an ICD was a concern for us. We thought that if the clot, which is sealing off the entry of the ruptured aorta into the pleural cavity, if that gets dislodged, then again he'll start bleeding torrentially, and he might even exsanguinate on the table. So we thought we'll not do the ICD first. Whatever clot is there, let it get sealed, and we'll give some time for it to form a hard clot. And we thought by the meantime, we'll do the endovascular repair and then do the ICD after the. So then patient was taken up for endovascular repair. We took a left femoral access, a right femoral open closure, and we took a subclavian, a radial access also. Through the radial, we inserted a pigtail and then took a shot. Then you can see we also had kept in a pacemaker, because while deploying the stent, we wanted rapid ventricular pacing. And you can see this is the true lumen, the darker dye, and the entire this portion is the false lumen. So this is the false lumen. So this is the true lumen. This is false lumen. The false lumen is nearly squashing the true lumen. The lower part of the dissection ended before the SMA. But however, the celiac trunk was involved in the dissection and it had already thrombused. So there was no concern for protecting the celiac trunk. Then a Valiant stent graft 30 into 30 into 130 centimeter was taken. We were intentionally jailing the left subclavian, because only then we could get a good proximal landing zone. You know, in patients with TVAR, if you want a good landing zone, you should require at least 15 centimeters of a healthy aorta. So we purposely jailed the subclavian. We didn't coil embolize the subclavian. We thought later on, if required, we can coil this subclavian. And another concern while closing a subclavian is one should be sure that it is not giving the dominant vertebral artery from that side. Luckily, our CT had showed that it was giving the non-dominant left vertebral artery. So we went ahead and jailed the subclavian artery to get a good landing zone, and then deployed the stent. Then ICD was placed post TVAR, and around 2 liters of blood was drained, and this is immediately after the ICD, and this is the next day. You could see the lungs are fully opened up, and the hemothorax had been drained. Patient was extubated after 12 hours with stable hemodynamics, and then was discharged after 5 days. So this is the post-procedure CT angiogram. You can see that there is no endoleak. The aneurysm has disappeared completely, and you could see only a small portion distally where the false lumen is still seen, but we need not chase this. The true lumen has grown bigger. Slowly it will squash the false lumen. And on follow-up, if it doesn't close now, we can definitely go ahead and do something for this. So this aortic aneurysm rupture is a very fatal complication, with mortality being as high as more than 90%. Luckily, both patient and we were lucky to come out safe. I would say the main thing was that the clot which had sealed the aortic rupture into the pleural cavity had got clotted, and it gave us time to do the procedure. The patient is fine now. So this was basically a case of aortic type B dissection, which developed a complication of aortic aneurysm of the false lumen. This aortic aneurysm ruptured, and it ruptured into the pleural cavity, producing hemothorax, and he came out of the complications safely. Now we'll go to case number 2. This was a 63-year-old gentleman. He was a diabetic and hypertensive for the past 10 years. He had chronic interstitial lung disease, for which the pulmonologist was giving him Perfinex 200 TID, and he was quite stable with this. And then he developed a large thoracic aortic aneurysm. This is the CT showing the large thoracic aortic aneurysm. All this happened in another center. So then he underwent TVAR for the procedure. The patient was doing fine after the TVAR, and he had no symptoms related to the aneurysm. Beyond 1 month, no CT was repeated, and the pulmonologist then asked for a CT for assessment of his ILD. So patient was asymptomatic as far as the aneurysm was concerned. The pulmonologist wanted a routine CT for the ILD, and when the CT was done, this is what we saw. The CT angio revealed a recurrence of the thoracic aneurysm at the upper end, but there was some migration of the stent graft. The level at which they had deployed was a little higher, but it had come down. So this is the recurrence of aneurysm because of migration of the stent graft. So now we had to take him and put in another stent graft with good overlap distally, and proximally also we wanted to keep it very high so that the graft does not slip again. So through the right common femoral artery access with micropuncture was taken, and then we went into the opposite left common femoral artery, through which we were going to puncture, place ProGlide sutures, and take the device. So just to make sure that your device is exactly on the common femoral head, it is above the bifurcation and below the femoral circumflex artery, the appropriate site, and the puncture is only anterior. For that is why we are keeping the pigtail on the head like this and then puncturing it exactly on the center, so that this makes sure that we are puncturing the anterior wall and the puncture is anterior, so that we don't have any issues with the ProGlide closure. Then this is the pre-procedure angiogram. You can see the large thoracic aneurysm here, and the previous stent graft, you can see there is an acute angulation. This was a concern for us, because taking this bulky device through this, negotiating through this, might give problems. So we were in a dilemma whether to do some pre-dilatation here at the narrowing and then take the device, or try the device first and then do it if it doesn't go. So, but somehow with manipulation we were able to take the device through this course, and then a 34 into 34 into 212 Valiant stent graft was deployed with the captive delivery system. It was deployed just distal to the left subclavian, where we had a good landing zone. This is the deployment of the device, and then the recapture of the spindle. So at that point, where we had a narrowing from the previous procedure, so we thought we'll dilate with the Reliant balloon. The Reliant balloon can go up to 46 millimeter, but we just could not break it. So then we did not further try to do that because of fear of aortic rupture. So we left some residual lesion which was there before, but there was some improvement in the diameter compared to the previous time. So since he was an elderly man, we had used too much of dye, so we just gave DSA shots to show that the stent graft has been well placed, no endo leak. And this is the distal portion also showing that the graft was well opposed. So the left common femoral artery was closed with the 3 proglide sutures which were placed in situ. The right common femoral artery was closed by groin compression. Then patient was shifted to CCU with stable hemodynamics. 3 hours post TVAR, patient suddenly started developing bradycardia and fall in pressures, but ECG did not show any changes on the monitor. So inotropes were started and BP was around 170. So we did not know whether was there any leak or perforation of the aorta, why his pressures were falling. We were more concerned with the device. But anyway, we had a routine ECG taken and the ECG showed acute inferior ulnar. We could not see this on the monitor somehow, but ECG showed an acute inferior ulnar. So patient was immediately shifted to the cath lab. Unfortunately, the left groin was closed with the proglide sutures and the right groin we had just given compression. So we had to go by the radial route to do the angio. The angiogram showed a diffuse LAD disease and there was a tight 99% lesion in the RCA, which was infarcting. So then we went ahead and did a primary angioplasty for the RCA. We did not give GP2BA, we only gave dual antiplatelet and did the procedure. The lesson we learned from this was, in the previous center, they had mentioned in the CT angiogram that coronaries were normal. So we went with that and did the procedure. So what we learned now is we always do an angiogram, especially if the patient is above 60 before doing a TVAR, so that we don't land up with such complications. So post TVAR and the primary PCI, hemodynamics improved after the primary PTCI. Inotropics were weaned off within 4 hours. He was extubated the next day and discharged after 3 days. PCI to LAD was planned after 2 months because we didn't want to do it immediately after a TVAR. So this was the CT angiogram 1 month post TVAR. You can see this is the old stent. This is the newer stent. The aneurysm has totally disappeared and there is no endoleak. So the take-home message from this case for us was never compromise on the length of the graft. The previous center, they had not given adequate 15 to 20 millimeter landing zone for the stent. That is why it had shifted down. One should always give importance to the neck. Neck could be varying shapes. It could be cylindrical, it could be conical, it could be funnel. Cylindrical is the ideal neck. It will hold the graft well. And you are always going to upsize the graft by 4 or 6 millimeters in an aneurysm. Dissection you you oversize only 1 or 2 millimeters. So when you are oversizing by 4 to 6 in a neck, it is very good. And you should have at least 15 to 20 millimeters if possible. Of course, when there is constraint, very rarely even 10 millimeters we have deployed, but that is touch and go, taking a risk. Even if you have a conical, it will still hold at the top edge, but only when it is a funnel shaped neck, it might slip into. So here you should see to it that you are adequately oversizing and you are placing well above the 15 millimeters neck zone. And always have a coronary angiogram before procedure with TVAR in high risk patients. So this was a patient who was post TVAR, the graft migrated, then he developed a recurrence of the aneurysm, and then after doing a redo TVAR for this patient, he developed a AMI following the TVAR, which was managed. So this is 3 months CT, and I am showing that both the grafts are working fine with no endoleaks. And coming to my last and third case, this was a 77-year-old gentleman. He was a diabetic and having hypothyroidism. He also had pulmonary tuberculosis. And while he was on ATT, around 2 or 3 months after the ATT, he was complaining on and off chest pain, back pain for 3 months. So a CT chest was done on 11/4/17. And to look for reactivation of tuberculosis, it showed there was a saccular aneurysm in the thoracic aorta. Most probably it was a mycotic aneurysm. So while taking up this case, we thought, this is the simplest case ever we could get. All that you have to do is put just a graft. You had good proximal landing zone, you had good distal landing zone. So we thought this was the most easiest case that we have ever seen. But unfortunately, his femoral arteries common femoral arteries were very small in size. You need at least 5 millimeter or comfortably 7 millimeter of arteries if you are taking a bigger device. So his common femorals were both less than 5 and it was not healthy. There was some calcium there, some atherosclerosis there. So we thought we'll take a iliac access. So a retroperitoneal exposure of the right external iliac artery was done with an oblique incision in the lower abdomen, and a 10 millimeter PTFE conduit was attached and brought out for access. So now we'll be taking the device through this conduit. And once the device is taken and deployed, then after that they'll ligate the conduit very near the artery, and then place sutures over it and leave it. So this is what we do when we don't have good access. So then iotogram was done using a 6 French marker pigtail, and you could see the saccular aneurysm. Then 30 into 30 into 117 millimeter valiant thoracic stent graft. This required a small stent graft because the length was not large, and we deployed the stent comfortably. So this is the retrieval of the nose cone after deploying the stent, and then after pushing the pigtail into the graft, we took an angiogram, and you can see that the aneurysm has been closed. Maybe you can see some small puffs going into the aneurysm, but that is just porosity. Due to porosity, which is known as type 4 endoleak, usually it disappears after 15 to 20 minutes if you wait and take an angio. Then we also post-dilated it with a reliant balloon, and then this was the end result showing a clean aorta with no endoleak. So this was the pre-procedure, and this was the post-procedure. A good job was done. The 6-month follow-up CT was done. It was fine. The stent was in place. There were no endoleaks. Patient was asymptomatic. He had completed his ATT, and so we thought everything was fine. But 1 year, 3 months down the line, post-TVAR, patient presents to the emergency with massive hematemesis. We stabilized him with ionotropics and blood transfusion, and then an UGI endoscopy was done. And this is what we found in endoscopy. There was a iotoesophageal fistula. So this is the esophagus. This is the rent in the esophagus, and through that rent you could see the stent graft in the aorta. So the constant pulsatile movement of the aorta had eroded the esophagus, and aorta also got eroded, and then the aorta connected with the esophagus, and he had developed hematemesis. Now this is a very serious and fatal complication. The dreadful complication. Conservative management is invariably fatal, so you cannot leave the patient like that. Surgical explantation of the aorta and homograft interposition was being done before, but it is a very complex procedure, and the mortality is very, very high, especially when the patients are all old, elderly, with a compromised heart and kidney. Nowadays, they are doing radical esophagectomy with temporary cervical esophagostomy and later reinstallation of the continuity by colonic conduit. This has a little better prognosis than the surgical explantation of the aorta and homograft interposition. But unfortunately, this patient, he refused any procedure, and then he went off home. He was stable when he went home, but after that, we lost follow-up. Most probably, he would have succumbed to the complication. So this was a patient post-TVAR, which was the most easiest procedure to be done, but unfortunately developed the most fatal complication, iotoesophageal fistula. Thank you.
Thank you, Dr. Elilan. It was an excellent talk. And moreover, it was an academic feast for us to hear from you about the long-term follow-up of these patients of aortic stent grafts. Usually, whenever we discuss, we see only about the acute complications. We are more concerned about managing these acute complications. Dr. Elian, can you please stop sharing? I think probably it is not.
Yeah. Stop sharing.
First of all, I would like to thank you for valuing the relationship. You mentioned in the initial part that I have a lot of regards towards you for maintaining that, valuing the relationship. The first case, I would say it was a very good thinking of you not putting an ICD before taking for a demand. I think that will be, I think, one of the best decisions. I would say it was, even for me, it was a very big learning for me. Okay, it is an just a reaction that whenever we see a hemothorax, just put an ICD. Okay, I think you
Really.
went ahead with doing the procedure, replacing a stent graft, and then putting an ICD. Probably, I would say that was one of the best decisions which was taken in saving the life of this patient. Regarding the second case, I have one doubt in my mind. The case was done very nicely. And you also mentioned that the patient had a normal coronaries before, like
I see.
during in the previous angiogram which was done. Okay. Post procedure, the patient developed an acute MI, occlusion of RCA. Do you is anyway related to the procedure, or if he was having an underlying atherosclerotic disease which would have like the
Yeah, I
rupture
mean,
and then produces
yeah,
acute.
it is unlikely. Yeah, it is unlikely because of the procedure, because we did not go to the ascending aorta at all.
Okay, we didn't go there.
Yeah. Yeah. So aorta, I mean, except for the O35 termo wire, which is symptomatic. So that could not have caused. And moreover, it was not a dissection. It was a clean lesion. The ostium was fine, and after that, you had a tight 99% lesion. And if it was embolic, you would have seen the emboli going down more distally into the. It won't stop at the proximal RCA. It would have gone somewhere down and obstructed. So, see, we have seen many times CT giving reports erroneously. The one patient came with a CT angio saying that he had a tight lesion in the RCA. He came prepared for angioplasty. And when we did the angio, we found a 90% tight lesion in the LAD, which was more tight than the RCA lesion. That was totally missed by the CT. And sometimes we have seen patients coming with triple SL disease, severe triple SL disease. The patient came prepared for angio, but we said we'll do a conventional angio. And when we did a conventional angio, there was only a diagonal lesion. The arteries were all heavily calcified, but no significant lesion, only a diagonal had a lesion. So CT sometimes can misguide us. So I think it is better to do a conventional angio, especially in patients who have risk factors for CAD. If they are elderly, I think better to do after all 10 ml, do a one shot of the left and right. You can do an angio with minimal dye. Unless patient has renal compromise, creatinine is high, then you have concerns doing an angiogram.
Yeah, regarding the third case, so it is just in my mind doubt. See, the patient was on ATT. So, do you think the tuberculosis or any? Of course, he's a very old patient. In any way, like any other etiologies, would you like to consider for developing a saccular aneurysm?
I mean, like.
Yeah.
Yeah, other than that, I mean, I cannot think of any other etiology. And moreover, the rupture which happened and the aneurysm site was a little different. This had happened at a point high above the aneurysm, and it was at a point where the aorta was bending and hitting the esophagus. So, because of friction only at that point, you develop this. But anyway, this patient had tuberculosis, and we are suspecting mycotic aneurysm. We are not sure whether it is really mycotic aneurysm. But sometimes this complication happens in patients who don't have mycotic aneurysm. Without mycotic aneurysm, for atherosclerotic aneurysm also, you do get this complication. So we are not sure. But since the site was different, if it had happened exactly at the site of the mycotic aneurysm, this aorta had given way, then probably you could suspect infection. But patient did not have, till that 1 year, 3 months after which he came, he did not have any symptoms. His pulmonary tuberculosis was fully treated. He was relieved of that symptoms also. He did not have any chest pain or difficulty or back pain or anything. So he was totally asymptomatic. If it were to be recurrence of infection, he should have been having some symptoms of reinfection.
The picture what you showed about the aortoesophageal fistula, actually it was a very horrific picture to see. But it was a very nice demonstration of how a stent aorta along with the stent graft, it has eroded into the esophagus, and both the things were demonstrated very well. It was a very nice picture what you showed. And one more question which is there in my mind, like how frequently do you see this stent graft migration? Because I find it a very rare phenomena which can happen with the migration of a stent graft.
Yeah.
Feel it is common thing to happen?
Yeah, it is very rare, not very common. See, if the neck landing zone is not adequate, if they have placed, see that previous stent graft, what they had done was they could have taken two stents. If they had overlapped with two stents, they would have covered adequately. But to avoid cost, for cost cutting, I mean, after all, one more device is another 4 lakhs to the patient. So to avoid that, they had placed one stent exactly.
Okay.
That landing zone didn't hold. So if you are having a good landing zone, I think it's almost. I mean, migration is only some 0.4% or very low, very low.
It's a very, very rare complication.
Yeah, unless the neck is bad or you have compromised on the length of the neck, only then this can happen.
You mentioned about the post dilatation. In some of the cases, I think we don't do a post dilatation.
Usually for aneurysms, you can always post dilate.
Yes.
For dissections, you never post dilate.
Yeah.
Dissection will progress. So dissection, it is a strict no. You never, but aneurysms, you can dilate. Now, suppose the post procedure, you see type 1 endoleak, you see some blood flowing in between the edges of the stent and the aorta, then that is a definite indication you should go ahead and do. But suppose your sealing is good and you don't feel, you feel that you have adequately oversized, it is already encroaching the aortic wall well, then you can always come out. It is not a compulsory, but in all aortic aneurysms, you can boldly do it. The reliant, you can take it to the extent you want. It is not that it will go to 46 millimeters. That is the maximum diameter. But you can stop at 30, 38, 40, whichever you want. So based on the size to which it is dilating the portion, you do it. And you don't do it everywhere. You only do it in the proximal end of the graft. Same balloon, even for the iliacs 10-11 millimeters, you use the same balloon. And if you have overlap two grafts, at the overlap you do. You don't do the entire aorta.
It was a very good demonstration of the various different varieties of complications of stent grafts. We have two cardiac surgeons with us, Dr. Gopal Krishnan as well as Dr. Naresh Hegde. Sir, do you like to have any questions to ask Dr. Elilan? Gopal Krishnan, please unmute yourself.
Dr. Srinivas is talking something. Is muted.
Yeah. Dr. Gopal Krishnan? Dr. Naresh Hegde? We are not able to hear you. Can you please unmute?
Yeah. Hello.
Yeah. Now we are able to hear you.
Yeah. Excellent presentation, Dr. Elilan.
Yeah, thank you. Thank
you. You tackled all those difficult cases. Anyway, nothing much to add actually. Yes, in the last conference also you agreed that mycotic aneurysms are better treated by this one open surgery because of the risk of rupture and all. Other the aneurysm treating you can treat by vascular treatment. So it's a very retrograde dissection, as you said, is a very formidable complication.
Yeah, this actually we had done it after 3 months of ATT. Then we took all markers of inflammation. We even took PET CT. It did not show any inflammation in the aorta. So then only we went ahead. But I take the point from you. Maybe because seeing retrospectively, I think probably if we had sent him for surgery, it would have been better. This complication would.
Yeah. Okay, sir. Thank you.
Thank you, Dr. Elilan. It was a very informative talk. It was very nice of you to join us. Okay, we'll see you again personally in some other conferences. Thank you very much.
Sure. I'll just watch Dr. Srinivas's presentation.
Yeah. We are waiting for the master of the masters to speak.
Yeah. He's a master of venous intervention for India.
Yeah, definitely. We have seen him presenting in many of the forums, showing his various interesting cases, how he has managed all his complications. It will be nice. Just a second. Sir, Dr. B.C. Srinivas, sir?
Yeah, good morning to all of
sir,
you.
Good morning, sir. Welcome, sir. Welcome.
Yeah.
So one small thing, he's come to a bookstall. What is it?
Yeah, this is there was a major technical snag. There was a major power failure in the area.
All right,
So
sir.
actually no internet access. I was getting ready and then I see there was no, then I had to rush to a bookstall behind my house, and then I logged in from the bookstall actually, and I'm presenting from there. Okay.
Sir, it's so nice of you. I really appreciate your commitment towards your academics as well as your presentations. Thank you so much, sir, for being with us. As I would say, yeah, sir, we are all eagerly waiting for your presentation, sir. Just a minute, sir. We'll just
Sure.
introduce you to the audience. Sir, can you please mute yourself, sir? Can you please mute, sir, for 1 minute? Why, sir?
Thank you, sir. We would have our next presentation by Dr. B.C. Srinivas. He is a professor of cardiology working presently at the prestigious institute of Sri Jayadeva Institute of Cardiovascular Research and Science in Bangalore. His area of interest is interventional cardiology and particularly peripheral and venous interventions. He has multiple national and international publications. He has written a chapter in a book on venous interventions in cardiac catheterization and imaging. He is a fellow of the Society for Cardiovascular Angiography and Interventions, FSCAI, fellow of American College of Cardiology, FACC. He will be presenting on the topic Overview of Venous Interventions. Over to you, sir.
Unmuted. Sir, unmute. Sir, you have unmuted. Can you please unmute it, sir?
Yeah, I have unmuted now. Now I
Yes.
need to upload
Yes.
my presentation. Shall I directly go to the presentation?
Yes, yes. So please go ahead with the presentation.
Can you
Please
see the
share.
presentation now?
We are not able to see, sir. Can
Can you see the presentation?
we are just waiting, sir. Still not it seen. Can
No,
you?
because I did not
Okay,
see
can you-
any sign to how to upload the presentation.
Yeah. Sir, can you click present? Present. There is one
Okay,
icon
one
there.
moment.
Yeah.
One moment. I'll just see that.
Yes, sir.
Present now. Okay, that.
Yes, sir.
Okay.
Yeah. Yes, sir.
Okay, entire screen. Okay. It's still yet to come.
Is it coming? Can we do?
Can you see? No?
Not yet, sir.
You are not given the access, sir.
Can you just see here? Mask.
Sir, first click present now, sir.
No, I'm not able to see the the slides on the. Is it sharing?
Yes, sir.
Now it's sharing.
Now it is started sharing, sir.
Okay, I'll just Now can you see the presentation?
Yeah. Perfect, sir. Perfect.
I'm so
Beautiful.
sorry. I just took some time to learn about this. Okay. At the outset, I would like to thank all of you for inviting me for this lecture on this wonderful Sunday. Greetings from Jaydev Institute of Cardiology to all of you. This is where I'm working, and over years we have acquired experience in the following subsets of venous diseases with respect to interventional management: Budd-Chiari syndrome, SPC syndrome, central venous occlusion, DVT with or without pulmonary embolism, pelvic outflow obstruction, the setting of chronic venous insufficiency. I'll take you through a case-based presentation, actually series. To start with, I'll start with IVC and the Budd-Chiari. IVC obstruction can be membranous, or it can be segmental. Segmental can be stenosis or an occlusion. And thrombus at the site of lesion can actually make life miserable, and in fact makes the management very difficult. But the main way we manage is balloon angioplasty and stent implantation. I'll take you through the state examples. Okay, this is how they actually present. Isolated IVC obstructions predominantly have marked collaterals over the abdomen and the thorax. You can see, and the flow will be below upwards because the IVC obstructed, and these collaterals try to decompress into the superior vena cava. When you have isolated hepatic vein without involvement of the IVC, predominant ascites, there is portal hypertension will be the manifestation. Where you have a combined IVC and hepatic veins, you have both ascites and prominent veins. CT forms an integral part of management because you can identify the exact site. Can you see the arrow, Subramani? So that can you see the arrow, all of you?
Yeah, we can see the arrow,
Okay.
sir.
Okay, because I can show the important things. That's the idea. So that is the web in the IVC, which is causing IVC syndrome in this case. So CT forms an important integral part. So this is a typical web. What we do in a web when they present with IVC syndrome with swollen limbs and prominent veins, we take them and study the web by injecting above and below the level of the web from the jugular and from the femoral vein, and study the thickness. And we study in two views, AP and the lateral. Once we do that, we try to cross it. You need a support catheter and a wire. Generally, a support catheter, I start with multi-purpose. But if multi-purpose doesn't give support, I then change over to sheaths. The Mullin sheath is one of the things. You can straighten out the tip of the Mullin sheath, and then you use the thermo wire to cross the web. Once you cross, then you actually, we are so used to the PTMC hardwares. We use the PTMC hardwares for web. We use that septal dilator to dilate through the web. And once we do that, we use the Acura, the Inouye balloon, and the shell. The compliance characters of Inouye and Acura are so good that, when you inflate, the distal portion of the balloon inflates, and then you pull it back against the web, and then further dilatation, actually, the proximal portion of the balloon dilates, locking the web in between the two dilated portions of the balloon, and the least compliant portion of the balloon, which has the maximum tensile strength, actually, when you further dilate it, breaks open the web well. So this is what exactly happens. You see, you get a great result like this when you have a you have an on table result. You see the collaterals go away on table because you have recanalized the IVC. The collaterals decompress and disappear immediately. And this case actually came back with restenosis. You can see that about 6 months later, and then we at that was the time actually I stented it, and this is more than 7 years now. It's patent. And in fact, he's working as a security officer because this guy was being kept as a cirrhosis of case in MD exams, and accidentally came to me in front of me. The moment I looked at it, was clear-cut IVC syndrome because there were so many prominent veins. And then we recanalized, and after recanalization, he just fell at the feet of our security officer and begged for a job, and he's the security one of the security guards in Jayadeva. This guy, 7 years he has been with us only now. So coming to segmental occlusions, sharp recanalization for crossing total occlusion of IVC is a common thing, especially when you deal with the segmental. We do it in multiple ways, either using the hard end of the thermo wire or the broken bone needle. For example, this is a case. You can see long segment hepatic IVC is occluded. You study in two different views, and then once you study, see, actually, in fact, it had been tried and failed twice. This is actually hard end of the thermo I've used with the Mullin's backup, and we could cross it actually. Once we cross, then the same procedure we do. use the septal dilator to daughter that, and then you use the balloon to dilate, and then you stent them primarily. You stent, and then stent gives a great result actually, and quite long lasting. Another case, this is you can see here, it's a segmental occlusion of the IVC in the hepatic portion of the IVC. And if you look at the anatomical characters, the 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 lower end for femoral approach is not very suitable in this case because lots of collaterals are around the occlusion site. To engage into the beginning of the lesion is the key to traverse through the lesion. So if you look at in this case, the nubbin here is very suitable to come from above. So we did not waste much time after few minutes of trial, because every time it was entering into collaterals there from femoral, we changed over to the jugular approach. And from the jugular approach, you can see actually I've taken a pediatric Mullin sheath and broken bone needle and maneuvered halfway into the lesion. Once we maneuver halfway, then we take it out and use Mullins does take a 1/8 wire. So you take a 1/8 terminal wire and then negotiate through the terminal portion, and then once you do that, then exteriorize the wire using a snare. Once you've done that, the rest of the process is simple. The other procedures are simple. You just balloon dilate it either with a small balloon or using a Acura. And because these are segmental, you definitely need to stent them. So stent gives great result, not only short term but long term also in such scenario. You can see this, the top two frames in AP and lateral view. In fact, this is one of the longest IVCs we have reconstructed. The entire length of IVC was occluded in this case. What you are seeing there is just conglomerate and bunch of collaterals around, Actually, that line which goes, that is the IVC. What you're seeing is the all collaterals draining through is like a system into SPC. So here we had to recanalize that. You can see that I have entire length using two long overlapping stents, entire length of IVC I have reconstructed from below the renal vein to till the RA-IVC junction we have reconstructed. So you can achieve good reconstruction of the IVC even in the long segment occlusions. Thrombus always is a major issue because, if you look at the data, before 1990s when they were doing balloon angioplasty for web, there were recorded deaths in the literature following web dilatation. The reason for that was there was no CT at that time, and they used to miss the clot below the web, and they used to dilate. This clot used to move into pulmonary circulation, and they used to die in the next 24 hours. So that's a major issue. So now with CT, you know that it is occluded at that point, and below that you have a large clot here, almost till the level of the renal veins. How do you manage this? You can see angiographically, you can identify it very well. You treat it with catheter-directed thrombolytic therapy, 1 lakh unit per hour. In this case, for 48 hours we have given, and then you clear the clot burden. The residual clots which are there in the wall, actually you can trap it using stents, self-expanding. For example, in this case, you can see not only we have recanalized that web with a stent, the wall adhering clots we have excluded from the circulation by using a self-expanding stent to trap between the stent and the vena cava wall. So this is another thought process. In fact, there are very minimum literature with respect to stent for trapping the clot. I'll show another case. These lesions can be very hard, very difficult to dilate and very painful. For example, in this case, when we were dilating, at this point, he was having severe pain. So we just left it. We leave it and then come back after 6 weeks. And you can see with 2 atmosphere, on follow-up, 6 weeks later, it yields very well. So this, in fact, if you look at the data from, George Joseph for the aorta also used to do the same thing. He used to just leave them and then bring them back and then redilate them. They used to write. So the same thing I have tried for IVC. IVC also it works well. This is an example. See, whenever you have an IVC syndrome, you always should look for associated hepatic vein involvement, because 70% of them will have some one or more hepatic veins being involved in the process. So web here, you should look for web in the hepatic veins also. This is a case wherein all the 3 hepatic veins were occluded, and you can see that there was the accessory hepatic veins, which was vein draining into lower IVC, also had a web at the IVC hepatic vein junction, which we actually stented and relieved the obstruction. So there the portal hypertension gets relieved if you open up the hepatic veins. Otherwise, the portal hypertension with symptoms will remain. This is again another IVC stenosis, gradient of 13 millimeters of mercury, more than 11 is significant in IVC. And then you have a web, very critical web. This you treat, not only you treat the IVC, but you treat the web also. And what happens is clinically you can see the ascites remarkably, in a week's time it resolves. That is the beauty. This lady came back with restenosis because we had done balloon alone, but we had to restent. This was about 6 months later. We had to restent it. So this is another example wherein there are many situations where the hepatic veins are completely occluded. You cannot access the hepatic veins from the IVC. Then what do you do? So here is a procedure which we undertake, which is where we combine with the interventional radiologist. What we do is, you can see this sheath. This sheath actually is introduced percutaneously through the skin, through the subcutaneous tissue, through the liver tissue into the hepatic veins, because you cannot enter this hepatic vein which is occluded from the IVC side. So what we do, we enter into the hepatic vein through the liver tissue percutaneously, so that we can recanalize into IVC from the hepatic vein. So this is an antegrade approach for the hepatic veins. Okay, if you come from the IVC, it is a retrograde approach. In this case, many a times you have to resort to sharp recanalization. In this case, we have used a Chiba needle to get through that lesion. Once you get through, then you pass the wire and then snare it out, and then you do your intervention either from the internal jugular vein or from the femoral vein. And this is, you can see, post stenting. Okay, the beauty is the portal hypertension resolves rapidly. This is another case example. In fact, he had undergone a right hepatic vein stenting earlier in another center. He was referred to us because not only this, even the mid and the left hepatic vein confluence also had been occluded. So this time we tried to cross that stent right in the right hepatic vein, but it had got occluded extensively. When we looked at the ultrasound Doppler, the extension of the lesion was quite deep, and then the entire vein was actually occluded. So hence, what we did, we used this confluence of the middle and the left hepatic vein. We thought we will recanalize this. So we have, and from the anterior abdominal wall, ultrasound guided puncture of the hepatic vein we have taken and introduced the 4F sheath into the hepatic vein, and that is the injection. You can see it is occluded. And this narrowing in the IVC is due to the cardiac lobe hypertrophy, which happens in all hepatic vein obstructions. So once we did that, we tried with the hard end of the termo, which did not succeed. So what we have done, because it was hard end of the termo, just takes a straight trajectory, doesn't bend. That is the problem. So we used a broken bone needle, which you can shape actually according to your requirement, and then we could actually get into the once we change the direction with the broken bone needle, we could get across into the IVC through that occlusion. Once that done, the rest of the procedure is simple, because you just pass the wire and exteriorize the wire, and then have a veno-venous loop, and then pre-dilate the occlusion, and then stent it. And once you get a great relief of hepatic venous outflow obstruction. So another case, similar, you can see here the needle we have introduced percutaneously into the hepatic vein proximal to the obstruction. So this is the obstruction sheath in. That is the IVC narrowed due to the cardiac lobe hypertrophy. And then we have here also we have actually hardened the regular green guide wire that we have taken and then shaped it and then crossed that occlusion point. Once that done, then we have pre-dilated and then stented it. This is done through the internal jugular venous approach. You can see that the hepatic venous obstruction is relieved. This was not only intraluminal obstruction, you can have obstruction IVC from masses pressing over. For example, this was a large metastasis in the liver from the CS stomach, and it was pressing over the IVC, causing IVC syndrome in this guy. It was more of a morbidity. So here, the procedure of venous stenting to relieve IVC obstruction was done as a palliative procedure because he was having severe edema of both lower limbs. So you can see that it's a self-expanding wall stent which has been deployed. And it give an example. See, this was the pressure gradient you can see that the RA pressure was 3 millimeters of mercury, and proximal to the obstruction, you see that the absence of this phasic variation, you can see the phasic variation is lost and the pressure is high, 18 millimeters of mercury gradient across. The moment we stand from, you can see that the gradient normalized. So we have up to 25 years experience. You can see this one came with restenosis, and this restenosis, you have to be ready for re-intervention. For example, here we have recrossed with using the Mullin sheath and the wire, and then we have dotted that entire lesion, and then we have dilated with initially with the Acura, and then Acura is a semi-compliant balloon. But here you can see this is Atlas is a non-compliant. This was very hard, needed a Atlas to dilate it, because Atlas is a non-compliant balloon. It doesn't even dog bone, even when you take it up to 30 millimeters, 30 atmospheres. In fact, this was the first case I did in 1995, actually. This was a teacher who had a web, you can see here. That time, digitalization was not done, so we used to mount that, from the film itself, we used to mount and make slides. This was and in fact, if you notice here, this, because we were unable to cross that, I had to use because we were doing PTMC quite aggressively in every day, almost 10 to 12 PTMCs we used to do. We were very well aware, and using the broken row, I recanalized it. But if you notice carefully, there is contrast extravasation. What happened was in the initial first 2 attempts, when I was trying to find out the suitable site, I had actually gone through the wall of the vena cava and strained outside. It has a bearing in this case, because this guy came back, in actually 2012 June. This is 95 done, and then 17 years later, he came back with restenosis. Not only restenosis, he also had a pseudoaneurysm at the site where I had created a, you can see this. This is the pseudoaneurysm. We initially had stained, so there was a pseudoaneurysm. Very interesting. He had recurrence of the web and a pseudoaneurysm due to the initial broken bone needle going through the vena cava wall. That was, so this actually I did a live demonstration to South Asia Pacific meeting. So what we did here, the idea is this was a narrow, path into that pseudoaneurysm. So I had to close this. You cannot use a covered stent because it has a hepatic venous entry there. So what I did, because it was a narrow, the flaps, if they open up, the web flaps could actually seal it. So we did it using a bare metal. Actually, this is a bare metal stent. You see, that's the Palmer's shanks. Okay, we not only excluded the web, but also excluded the pseudoaneurysm very well. That also disappeared. So we were 2-in-1, actually. You can see that this was the web with pseudoaneurysm, and this is post-procedure result. Sometimes this IVC thrombi can embolize. For example, this was a case where in nephrotic syndrome, you can see came with pulmonary embolism. And the reason for pulmonary embolism was this clot. You can see here. This clot was coming from the renal vein in a case of nephrotic syndrome and occupying this. And this is in the hepatic segment of the IVC, and it's a very large clot. How do you manage this? This is a very, tricky situation, because you don't have space towards the right atrium to put a filter to do any mechanical aspiration, or so in such situation, what I do is below the clot I give catheter directed thrombolysis and serially monitor them. And when now the patient had IVC syndrome due to clot. Now you see the brisk flow is there. Now is the time. The residual clot, what I do is I use a self-expanding stent and trap the clot, so that the clot gets trapped between the stent and the vena cava wall, and then you continue anticoagulation. It will disappear over time. This is what has happened. Actually, she is. We have 7 years follow-up on her. She is doing well, and she got, in fact, treated for even the nephrotic syndrome. She is doing well. So angioplasty stenting has come a long way in the management of the IVC syndromes and the hepatic vein obstructions. No doubt about it. The second subgroup of diseases where we have acquired experiences the central venous occlusions in dialysis dependent. These are moribund cases. You look at these pictures, it is so moribund. And these guys, for the purpose of dialysis, you need a high flow in the veins. To create a high flow, what they do is they create an arteriovenous fistula. That ensures them more than nearly 180-200 ml of blood flowing through the venous per minute. That is what they need to draw into the dialysis circuit and clean it and give it back. So What happens is the CRF is a systemic inflammatory state, and the comorbidities like diabetes, hypertension also causes systemic inflammation. All of us are aware. And repetitive catheterization through the central veins with eye flow causing shear stress from the brachial AV fistula. All these factors conglomerate, you see, and then it causes central venous obstructions. For example, CT identifies it very well. You can see here, this is the axillary vein, the subclavian vein, this is the innominate, that is the jugular. Where they have catheterized, where the catheter is gone, there you can see that there is an occlusion. So CT can actually identify this occlusion and the extent of occlusion, because it is extending into the internal jugular, into the subclavian, and then into the innominate vein. So, and you can actually study the anatomy very well with CT venogram. So what we do here, for example, this is a left innominate vein stenosis. So here we cross the lesion and then exteriorize this wire through the femoral and use atlas balloon. We use smaller balloon to dilate initially and then the atlas balloon. Why atlas? Because this non-compliant balloon breaks these venous lesions very well, and we do achieve a great result like this. When we achieve a great result like this, we don't stent them. This was an unfortunate guy. In fact, this was the first patient whom I did central venous occlusion angioplasty. This guy had undergone a left brachial AV fistula, which got infected. He had a cellulitis and went on to have an amputation for this, unfortunately. And they created a right brachial AV fistula. Now, the right innominate and the subclavian vein got occluded, and the right upper limb became edematous and severely hypertensive. Venous hypertension he developed. So, now this was the scenario. You can see here the these cases what we do. So you can see, okay, you can see that we have accessed this the right axillary vein, because the right subclavian innominate entire length was occluded. What I try to do is approach them antegradely from the axillary brachial or the subclavian vein, and retrogradely from the femoral vein. So that you have a antegrade and a retrograde approach. Like any other CTO in the body, we do approach these antegradely and retrogradely. Here you can see, to stay close to the occlusion, I have entered into the axillary vein. This you can do either fluoroscopically or using ultrasound Doppler. Then we take a support catheter. In this case, it's a curved catheter with the thermowire. You try to, you need to spend a bit time because you should really persevere, because these are very hard lesions. Once you cross, then the rest of the things are simple. You exteriorize the wire. So by exteriorizing, what we are trying to do is we have achieved a veno-venous loop from the right axillary into the right femoral. That gives you strength to take your hard waste balloons and the stent easily. Now, and then pre-dilated the lesion with a balloon, and then after that we have stented it, and you get actually good result with a very good runoff. And in fact, the edema subsides. In the next few days, the entire edema will be gone. This is another example: right innominate vein total occlusion, left innominate vein normal. So here again, the anatomical characters were pretty, favorable for intervention from. So that's how we do. You fluoroscopically you inject, and then as the contrast goes, you puncture into it. So this is what we do, and then you use a support catheter and cross it. Once you cross it, then you use the long sheath to go close to the lesion, and then take the atlas balloon, dilate initially small balloon, then create a path, and then you use the atlas balloon to dilate it appropriately. Once you do it, if it is a long occlusion like this, we generally stent them with a great result. But you have to be prepared for restenosis and such cases. This is in fact, 19 years history of facial, neck, and upper body swelling. This was a chronic occlusion of SVC, both innominate veins. Actually, you can see the SVC is occluded, right subclavian into innominate is occluded, left innominate is occluded. So In fact, the anatomy was favorable to start the case from the right subclavian. We started, but we ended up in the subintimal plane. We could not get into the SVC here, so we left it. We came from the right femoral, that is the sheath. Here we got lucky because it stuck into the lesion and looped. Whenever it loops in a venous occlusion like this, whether it is in the IVC, whether it is in SVC, whether it is in iliac veins, I've seen it generally knuckles through the lumen and then enters the true lumen. And once that done, we exteriorize that. We established a actually now veno-venous loop between the left subclavian and the right femoral vein. Once that done, then you can take the your balloon easily, because you can pull and push and take the balloon in easily. That is the dilator to just dilate, and then after that you use the atlas to do a good dilatation. So we created one, that is one path was ready. Now we had to get into the other innominate vein here, because the we had failed from the right subclavian approach. What we did here, now we used a broken needle, and we have identified we have seen this in multiple views, and the Elevo view was showing this very promising, because the wire from above, we had just kept it there in the false track. Now you can see that the entry of the left innominate here, the right innominate here. So once you identify that, then you use the broken row and then cross it, and then you dilate them. So the same technique, use the pre-dilate the lesions well. Once you have pre-dilated, you see both the innominate veins have been recanalized. Now the part of stenting, the two overlapping stenting from in the both the subclavian back into the SVC, you can see you get a great result. Like this is all this is again 7 years old now. The beauty is edema resolved rapidly in 24 hours. Headache decreased, vision was better. So he is doing well. Sometimes you have combination of lesions. For example, in this case, this was a dialysis dependent CKD patient. You see that the IVC also was occluded in this case, and he has a innominate vein long segment occlusion. So we had to go to innominate vein. We had to first recanalize the IVC. So first we recanalized the IVC through balloon dilatation. Once we did that, then we went into there again we could not cross. So we had to resort to sharp recanalization with broken bro needle. Initially there was some extravasation of the contrast, and then we redid the procedure. We could ultimately get into the true lumen. Once that done, the cross with a wire, pre-dilate them with small balloon, and then take the atlas. And the same atlas actually we have used to dilate the IVC and got the IVC flow also. The and then stented the. You can see that then we have stented the right innominate, getting a good result. So this is again, you can see that there is right in this was a SVC obstruction. This was because of bilateral innominate vein occlusion. This was a amazing case, because what we did, we recanalized only one innominate vein, and you look at the result. It was like this actually, very volume overloaded. This patient actually was unable to lie down, and used to sleep in sitting posture for more than a year. He had not lied down. This was the first time, that is on the cat table we had to for the procedure. You see that at admission he was like this, and then 1 month later he became like this. But this guy, after balloon dilatation and stenting of the right innominate vein, went into recurrent pulmonary edema. In fact, we had to, because there was a volume shift from the third space into circulation. So you have to be very careful. If in SPC syndrome, you have to warn your nephrologist to dialyze them and remove extra 4 to 5 liters per day, so that the movement of the fluid from the third space into the circulation can cause pulmonary edema. In this guy, we had to ventilate him for 7 days actually, and then dialyze him almost 10 to 12 days every day, removing 3 to 4 liters, and that is how he became like this actually a month later. And similarly, this is another example. Right innominate is occluded, left innominate is occluded. You can actually, you see then two overlapping stents, and you can reconstruct them into SPC. So this is again a SPC syndrome, and this was, you can see SPC was occluded. So you even creating one, if you recanalize into one innominate also, they do very well actually. It decompresses the SVC syndrome very well. For example, you see here post procedure how they become. The beauty of the procedure is that. Third group is we have acquired experience with pharmacomechanical approach for proximal DVTs. Proximal DVTs in selective cases, we know, though the studies did not show much with for every case, if you do catheter directed thrombolysis, it may not be a great idea. But if the clot burden is large, then you have a great role for pharmacomechanical approach. This prevents pulmonary thromboembolism as well as the post-thrombotic syndrome, that is chronic venous insufficiency. I'll just show you a case example. This was a young guy who, following motorbike accident, he was immobilized and given NSAIDs, unfortunately. And then he had developed thrombosis of both lower limb veins and IVC, very large clot burden. You'd see below the level of renal vein, it is occluded. And then this is the right iliac, which is occluded. And then you have the left popliteal SFV iliac system is occluded with clot. So what we did in this case, we went for pharmacomechanical approach. When you are doing pharmacomechanical approach, the chance for embolism is there. So we temporary filter sometimes, very rarely I use this. Very occasional cases only I use IVC filters. I'm not a great fan of IVC filter. In fact, my usage is very, very low. So what we did here is mechanically aspirated the clot from the iliac and the IVC. You can see large amount of clot burden came out. Then infused urokinase through the catheter into the iliac vein, IVC, and the femoral, and through the sheath. And you see that the iliac vein, IVC, completely recanalized, and the left also. In fact, in this case, both the lower limb veins as well as the IVC got completely recanalized. Once that done, we remove the filter immediately because there is no role for filter to stay anymore. So there are certain situations where you have to stent even in acute DVT. For example, if there are residual severe lesions in the pelvic venous outflow after you have cleared the clot with anticoagulation and thrombolytic therapy, you need to relieve the pelvic venous outflow obstruction. There you have to stent. Another setting is May-Turner syndrome. For example, this is 55-year-old lady who had major left lower limb DVT with gross edema of the left lower limb, which persisted even after thrombolytic therapy through the catheter-directed thrombolysis. The reason for this persistent edema was, you can see the clot in the iliac veins and the femoral system and the popliteal system had completely cleared. But the pelvic venous outflow you see here, it is still occluded. So this is a classical example wherein you can stent and relieve the obstruction. Once you do that, you can see that the edema rapidly decreases and the symptoms disappear. There's another situation, 42-year-old lady presenting with extensive DVT where there were multiple blisters, phlegmasia cerulea dolens. You see, this is a very, see this is impending venous gangrene. If you don't treat, they go for amputation. So these are extreme cases of DVT. What we do here is you just use ultrasound Doppler guided entry into the popliteal vein. In this case, 8F sheath has been introduced, and then do a catheter directed thrombolysis. In this case, actually, we gave streptokinase. In streptokinase actually cleared the thrombus in the iliac system, femoral system, popliteal system. But you see there, still that last part is still persistent. In fact, this was a web actually in the iliac vein. So this was a clear-cut May-Turner. This patient is in prone position. That's why it is seen as though it is on the right. It's a left eye common iliac vein. This is a typical case where we go for balloon dilatation and stent implantation. Once you do that, see, this is the wall stent, 14 into 80 millimeter. So you see there is a rapid decompression of the pelvic venous outflow. Next day, you see the blisters disappear and the wound heals. And by 3 days, you see the healthy tissue already appeared. So the very gratifying relief you can find inside. So you have to actually selectively use this pharmacomechanical approaches or stent implantation in this kind of cases. This you have to identify and treat them because the result is very gratifying. So there is a role for pharmacomechanical approach as well as there is a role for stent even in acute DVT in a very selected group of patients. The other group of patients where we have acquired experience is the chronic venous insufficiency with ulceration. This is 8 years ulcer, not healing. The reason is he has a occlusion of entire iliac vein. This is a chronically thrombosed, untreated DVT, which has become like this. Now, this you can recanalize. See this? You can actually use balloon angioplasty and stent implantation, but very difficult to treat because very hard for cicatrized lesions to cross. It takes hours together actually. But the result is gratifying. The wound heals very rapidly. 8-year ulcer, in less than a week it heals. That is the beauty. Similar situation. This is again a 8 years chronic ulcer. You can see how bad the limb is, and here again, in this case, right iliac, left iliac, entire IVC is occluded. So how do you manage this? So this again is amenable for PT and stent implantation. So we do serial balloon dilatations from both the sides. We access both the femoral veins and then take 2 wires into the IVC, try to recanalize through serial balloon dilatations, and then you can see after it will, if you just do balloon dilatation, it is not sufficient. You need to stent them because these are long occlusions. In this case, 2 long stents we have implanted from both the sides. So you can see that is how you can reconstruct. So left iliac is reconstructed, right iliac into IVC is infiltrated. So the entire IVC and the iliac veins are reconstructed. Once you do that, you see the healing of the wound, day 1, day 2, day 3. I'm talking of a 8 years history, 8 years wound healing in days. That is what you are going to see if you recanalize. So to conclude, endovascular therapy is evolving as a primary mode of therapy in management of veno-occlusive disease and venous thromboembolic diseases. We have acquired experience in IVC obstructions, hepatic venous outflow obstructions, SVC syndromes, central venous occlusions, pelvic venous outflow occlusions in acute DVT, as well as chronic venous insufficiency. Of course, endovascular management is less invasive compared to surgery, and equal efficacy and midterm patency are comparable to surgery. Long term, we needs a multi-center registry because these are very special cases where you don't get big numbers actually. So you need to have multi-center registry for long term. But going by our records, IVCs are still patent. SVC syndromes are still patent. Central veins come with recurrent restenosis. We redilate them. So be ready in case of central venous occlusions if you treat them to retreat them with balloon angioplasty. I thank you once again for patient hearing. Thank you, Subramanian, for giving this opportunity to speak to you. Thank you.
Thank you very much, sir. First of all, I really don't have words for your commitment. You had so much of difficulties in connecting to us. Then I think you went to a bookstore. This is what I was told.
Yeah, the bookstores.
I can see the books at your backdrop.
Yeah, owner is close to me, so I told him he was at his residence. Actually, I just rang up in 5 minutes. He just ran and came and then opened the stores for me. All the thanks to him. Okay.
One small section, sir. Can you please stop sharing, sir? I think it is echoing. Stop
One
sharing
moment.
it. Yeah.
Okay, I'll stop sharing.
Sir, it is my personal question. Hello? Sir, it's my personal question to you. See, your name is B.C. Srinivas, and then you do only Budd-Chiari syndrome cases. Is it that BCS is an authority on BCS?
Subramani, no, actually, let me tell you. See, if we do 30 cases in a day, 2 venous interventions I do. Actually, 28 coronary and structural. I don't show any of that in any of the meetings because everyone else is showing. There is no need. So, people need to learn more about these procedures which are done rarely. So I present only this so that everyone learns. That is the idea. Yeah, it is a coincidence.
I don't think it is just a coincidence, sir. I don't believe that. Because you have got cases from 95. Second thing what I've really learned from you is about the use of this catheter-directed thrombolysis in these patients. In one of the conferences which I attended about 3-4 years back, you showed a step step-by-step way in which how you exactly you should go to the vein, how to which catheter to use, where exactly to place the catheter, and then how to start thrombolysis. I think that was a real eye-opener for me too, to start catheter-directed thrombolysis, maybe about 4 or 5 years back. I don't remember exactly which conference it was. So it was really a nice, very good presentation, and it was a visual treat for all of us. And I want to ask you one question, sir. Do you use these CTO wires in any of these procedures, or you are confident only with these thermo wires? You get a good result with this coronary wires. I mean,
extremely rare.
dedicated
CTO wires.
Yeah.
CTO wires. Actually, I don't. Only one case I can recollect. Okay, only one case. Otherwise, all the other cases we have done with thermo alone.
Okay.
Thermo, yeah.
That's wonderful, sir. Wonderful.
Rajesh, good to see you. Rajesh, you are muted.
Yeah, can you please unmute?
Rajesh, unmute.
So nice, BC, to see you, and Subramaniam as well. As Subramaniam is asking few questions, let me comment and ask few questions as well from Srinivas. Yeah. So BC is made for BC. That's all. He has an expertise to deal with the venous intervention left and right. I was just commenting one of my residents that okay, he is the expert to do each and everything, whether IVC filter block, he can do the intervention of the blocked IVC with the filter as well. So this is his greatness and expertise in the venous intervention. Second comment is about, say, as you was asking about the CTO wire, BC must be using the reverse end of the thermo wire, so which is more than the, say, CTO wire for the peripheral intervention. Am I correct, BC?
Yeah, occasionally I have used the reverse end of the thermo. One problem with the reverse end of the thermo is remains straight and straight. It takes the straight course. It doesn't bend. So for that, our regular, wire which we use, the green wire, that actually you can give a shape, and the shape memory is much better with this regular wire. So when I need a shape, when I need to give a shape, I use the regular wire. When I need a straight trajectory, I use a thermo wire. So when I need to bend a bit more, then I think and inject through the occlusion, I use the broken bone needle. It changes depending upon the case. Looking at the occlusion, studying through the CT and both the angiograph, then I take a decision on table what to do. But yeah, it's a learning process. It's a learning process. But I think any one of you can do it. I don't think these are only thing is, yeah, I get referrals because of the being while doing it, we are getting references. That's how we have learned this. Otherwise, most of you can do it actually.
Sir, I don't agree with the last point that anyone can do it. I don't think so, sir. And with all potential complications. In one of the conferences, you had showed the way how you managed a rupture of a IVC while doing the CTO, and you had your innovative way of tackling it by using a balloon. The balloon, you cut the balloon and put it across, and then you trimmed it, and then that was really a treat for us to see.
Yeah, because there was no covered stent. We used the balloon actually, and then that cylinder portion of the balloon, we cut it and mounted on a plain bare metal stent, and then sutured it on site, and then created a covered stent and did it actually.
that was really a very innovative way, and the patient's life was saved at the end. Otherwise,
the same thing we used to do in early part of the coronary interventions also. We used to use the same balloon, coronary balloon, you cut it and then suture it and then make it a covered stent and use the perforations also we used to do earlier.
All right, sir. All right.
Thank you once again for everything. Thank you.
Sure. Thank you, sir. Thank you, sir, for being with us. Thank you very much. With this, we'll move to the next presentation by Dr. Rajesh Vijayvargiya. This is a very unique presentation in the way that it's a very challenging, as well as I have not heard anyone giving a talk like this earlier. The use of imaging, IVAS and OCT in peripheral interventions. This is a talk which I was very much eagerly waiting, and has got a big series also on this to present. Welcome, Dr. Rajesh Vijayvargiya, for your talk, sir. I
So,
tell Dr. Jenny to give a brief introduction about Dr. Rajesh Vijayvargiya.
should I go ahead?
Thank you, sir. Next talk will be by Professor Rajesh Vijayvargiya. He is a professor of cardiology, presently working at Postgraduate Institute of Medical Education and Research at Chandigarh. He is a member of a fellow of the Society of Cardiovascular Angiography and Interventions, FSCAI, fellow of American College of Cardiology, FACC, Cardiology Society of India, Endovascular Interventions Society of India of Heart Research. He has many publications, 85 and more international publications in renowned journals, 50 and more Indian publications. He will be presenting on the topic Role of Imaging by OCT and IVUS in Peripheral Interventions. Over to you, sir.
So, my slide is
Sir, we
visible.
are not able to hear you. Can you please unmute? We are not able to hear you.
Okay, just hold on. Just hold on.
He's presenting. Okay, fine. All right.
Okay, are you able to hear me?
Yeah. Now we are able to hear you. Now it is
And
clear. Yes, sir.
now let me share the slide. Are you able to see my slide as well?
No, sir, not yet. Can you please share the slide?
Share the slide. Present now. Your entire screen. Share, please. Share.
I should mute. Someone is there. Yeah. Yes, sir. We can see the slide now. We can see the slide.
Fine.
Yeah, perfect.
Great. So, Subramaniam, thanks for the invitation, and it's a pleasure to have a talk on this particular topic, which is new for me as well. Though I had done few imaging in the peripheral intervention, but it was something very nice for me to prepare this presentation for the meeting. So glad and honored to be there with you all to present on this topic. So there is no conflict of interest. As a cardiologist, we all know that intracoronary imaging do make a difference in technical and also the clinical outcome for the percutaneous coronary intervention. This is the comparison between the CT angio versus conventional angiography, a marked difference which has further improved with the use of intravascular imaging, which include IVUS and the OCT. OCT do have the advantage of say 10 times more resolution compared to intravascular ultrasound, though the penetration is less common used for the coronary, which include IVUS, virtual histology, IVUS, angioscopy, OCT, and knee. As an intervention cardiologist, we all know about that there is a definite role of this imaging during the PCI, which includes say pre-intervention for coronary like plaque characterization, lipid, calcium, fibrous, cap thickness, thrombus, etc. Regarding the length and the sizing of the stent which has to be used for the lesion. Post-intervention, it's stent optimization, expansion, and the malopposition, which can be very well assessed. And at the follow-up, whenever there is a stent failure, one can then assess the mechanism. So this is all about, say, use of this intravascular imaging for the coronary intervention. The same thing has been extrapolated to peripheral intervention, but then there are certain limitations. These are that there is a lack of robust data and randomized trial for the use of this imaging entity for the peripheral intervention. Literature-wise, there are more of the case report and a case series available for this particular entity. And this, of course, do have a technical improvement in the outcome whenever you do the peripheral intervention, but then clinical outcome yet to be certain. So let me go ahead from above down, from brain to say lower limb, how the imaging do help for various intervention. For internal carotid artery stenting or intervention, the plaque characteristic like intraplaque hemorrhage, lipid fibrosis, necrosis, calcification, and mural thrombus can be well assessed by intravascular ultrasound. And then there are two studies which have shown that equilucency and heterogeneity of this plaque is associated with the poor prognosis in the patient with the high grade carotid artery stenosis. However, the use of these imaging devices for the carotid stenting has certain limitation because there is manipulation of these devices across the stenosis, which can result into, say, cerebral embolism and stroke during the procedure, and therefore imaging is usually been avoided during the carotid stenting. It's preferable to put a distal protection device prior to go ahead and have a minimal time to the carotid stenting instead of doing the imaging. So that's the limitation of use of imaging for the carotid stenting. Let's have a look on the aorta. IVS, especially of 8 to 10 megahertz, has been used in certain cases and the case series for TVAR and EVAR. It's mainly been used in those with a type B complex aortic dissection, type A dissection, blunt and penetrating aortic trauma, penetrating aortic ulcer, and intramural hematoma. On the right side upper end, you can see recently I come across one patient who had a recurrent stroke in last 3 years and was found to have an eccentric ascending aorta plaque, which can be very well visualized in the CT angiogram. We did the cine angiogram, which was more or less normal. We couldn't localize this eccentric protruding plaque in the aortogram. So this is the case which can be very well visualized by, say, intravascular ultrasound to look for how much it is protruding and why it is creating so much of problem. So that's the advantage of intravascular imaging for the peripheral vessels like aorta. For say type B aortic dissection, which is complex one, this intravascular imaging, intravascular ultrasound do help to an idea of the site of intimal tear, visualization of true versus false lumen, and then accordingly you can track your device instead of putting a graft stent across the false lumen. You can very well visualize which is the true and false, and then accordingly do the intervention. Extent of graft stent can also be done with the imaging that you can whenever there is a multiple entry point for a type B dissection, you can very well cover the extent of the dissected segment instead of primarily covering the proximal most entry point. Sometimes there is a doubt about the involvement of the visceral artery, whether it's from the true or the false lumen, which can be very well assessed with the use of IVUS. Let's look for how does imaging do help for the mesenteric and renal artery intervention. Virtual histology IVUS has been used for renal artery plaque assessment. And in one of the studies, it is found that the necrotic core size and deterioration of renal function during the PTR and stenting of the renal artery has been correlated well with the use of virtual histology IVUS. IVUS has also been found to be useful for two studies where they have used for the fibromuscular dysplasia to have an adequate vessel dilatation and have an optimal result following the balloon dilatation as such. There are multiple case reports of the IVUS to guide angioplasty, stenting, and atherotomy in renal, celiac, superior mesenteric, and inferior mesenteric artery. However, the overall evidence is quite limited for use of imaging for this intervention. Now let's have a look on how the IVUS do help in iliac lesion. This is one of the famous study about the beneficial effect of IVUS for iliac stenosis. So there was aortoiliac lesion. IVUS arm do have 49 cases and angiography arm had 22 cases. And then like the coronary, the 40% of like for the coronary where we do have a change in the decision making in around 50 to 70% of the cases following the use of the intravascular imaging. Here the 40% of the cases following the use of IVUS, there is a change in stress D and the stent deployment procedure was a little bit changed. Following the use of imaging, if you see the long-term patency, it's a 3-year primary patency in the IVUS arm was 100%, which was only 82% in angiography arm with a significant value. Again, the 6-year patency, it's again the 100% vis-a-vis say 69% in angiography arm. Secondary procedure is on the lower side. It was nil for the IVUS arm, while it's a 23% of the patient who had now secondary procedure as well. So this is one of the study which has shown a encouraging result and good clinical outcome to the extent of 6-year follow-up with the use of intravascular imaging for the iliac lesions. This is something a newer device which is at present not available in India. Pantheris system, which has now catheter, distal catheter with a rotating stainless steel cutter blade and an internal OCT fiber and apposition balloon. So three things are there. One for atherectomy, that's the cutter. Second is the balloon dilatation, which can very well dilate the lesion. And third one is the OCT to look for how much optimal result we have come across. So this is the promising new technology with potential to improve the long-term outcome in the patient who have a high atheroma burden and who do have, like say, calcified lesion. So this is one of the trials, the Vision trial, where this particular catheter was used for the intervention. A prospective neuropopliteal lesion was there. 104, there's around 50% of the patients were treated with the Pantheris alone catheter, which includes both balloon dilatation and atherectomy. Around 40% patients were treated with this particular catheter along with adjunctive angioplasty, and only around 5% of patients had an additional stenting after using the catheter and angioplasty. So this is the way the treatment has changed. Most of the time in the peripheral intervention, we do go ahead and do the balloon dilatation followed by stenting. But then in this particular trial, after the use of atherectomy catheter and optimization with the OCT, the percent of the patient who had primary stenting was drastically decreased to say 5%. And if you see the 6-month clinical outcome, only 6.4% of the patient required a target lesion revascularization, and the rest of patient did well. And therefore, this study has shown that atherectomy of femoropopliteal disease is safe and effective. And with the use of OCT, there is a precise removal of the plaque without having adventitial injury and the perforation, which is the risk in this patient, especially those with the calcified lesion. This is regarding the OCT to help an idea about how the therapy is effective to decrease the thrombus load. So two arm, one is aspirin with clopidogrel, another one aspirin and ticagrelor, and at 6 months of follow-up, repeat OCT was done after stenting the lesion. At the baseline, there was a thrombus load, which is visible in this diagram, and at the follow-up with the ticagrelor versus clopidogrel therapy, the ticagrelor therapy was found to be more effective in resolution of thrombus compared to say clopidogrel arm. So this particular study has again shown how you can assess this lesion following stenting at follow-up to look for the thrombus, residual thrombus load which was there after the stenting. Regarding say CTO cases of the femoropopliteal lesion and role of IVUS guided balloon assisted re-entry, this particular study has shown that 10 femoropopliteal CTO patient, and at the 6-month follow-up, the patency was 100%. So, like say for the coronary retrograde or antegrade entry, and the role of IVUS to look for the entry into the true lumen from the subintimal layer, same thing can be extrapolated for the peripheral intervention when you have entered subintimally, and then you have to re-enter in the true lumen to have the final angioplasty and stenting across. So therefore, the IVUS do help to improve the entry into the true lumen for the CTO lesion, and therefore maintain the patency at follow-up as well. This is about the role of, say, virtual histology (OCT) in the calcified femoropopliteal lesion. It's an infrapopliteal lesion. Here, the particular case had an infrapopliteal block of the positibial artery, which was the calcified one, and with the orbital atherectomy, it was dilated across with a good result. And the OCT did show the calcified lesion, and with the atherectomy, there is a fracture of the superficial calcium across, and good end result which could be visualized with the OCT. Here in this particular diagram, this blue one is the calcium, green one is the fibrosis, and red one is the atheroma. So overall, for the femoropopliteal disease, the advantage of the imaging is primarily because of the following reasons: the selection of ideal stent, landing zone in the stent length, proper vessel and stent diameter sizing can be done, enhanced recognition of vessel dissection after the balloon dilatation, and detection of incomplete stent expansion. The particular study by Mickey et al. Has shown that preliminary research has identified the MSA of, say, 15.5 millimeters squared by the IVS, which can give an idea about, say, ISR of a SFA intervention. So this is something which we preliminary come across, that an area which is, say, less than 15 millimeters square for the peripheral intervention, especially for the SFA, is the one which is prone to an ISR, and then one can achieve, say, more than 15 millimeters square for any peripheral intervention. The same thing, a law of, say, 5, 6, 7, 8 is there for the left main confluence during the intervention, while where the area is, say, more than 5, 6, or 7 or 8 millimeters square for the coronary. Same thing is there for the peripheral. In this particular study, where the area should be, say, more than 15 millimeters square to have a good outcome at follow-up. Another study for the BTK intervention, the mean balloon size has significantly improved with the use of IVUS in 88 patients compared to angiography arm, which do have, say, 242 patients. Wound healing rate was significantly better with the IVUS arm compared to angiography arm. However, there was no difference between the, say, technical success and the complication, freedom from target lesion revascularization, and limb salvage rate. So technically speaking, there is improvement with the use of imaging in various peripheral intervention as per the end result is concerned, but the clinical outcome is still remain the similar one. So this is about the meta-analysis and systemic review of the observational study. It is not the randomized study, observational study, and what the conclusion is about the IVUS is that uh, this is about the 9 observational study and around 93,000 patients, which include 1,700 of the IVUS arm, and the angiography include 91,000 patients. Mean follow-up was 24 months, and then there is a similar patency and re-intervention rate in the true arm, which is suggestive of that as per the clinical outcome is concerned, these data are not sufficient to go ahead for, say, intravascular imaging for the peripheral intervention, though the technically we do have a good result following the imaging. So this is all about the role of imaging in the peripheral intervention, and we do have our experience of doing it. Recently, we had now one case who had now bifurcation stenosis of transplanted renal artery. He was a 58-year-old diabetic chronic kidney disease patient who had kidney transplantation 4 months back, and here the atypical way to go ahead for where the anastomosis of donor renal artery was performed by double barreling of both superior and inferior renal artery. A confluence was made of the two, and then this confluence was anastomosed with the recipient external iliac artery. So this is not the usual way the transplant renal artery anastomosis has to be done. Because of the particular donor renal artery, which has the both superior and the inferior renal artery, a confluence was made and anastomosed with the recipient external iliac artery. However, 4 months later, down the line after the transplantation, he had
even the use of IVs in post-transplant recipients. I think it was a wonderful demonstration. You also reviewed the complete literature from head to toe, from the
that's
carotid
right.
arteries till the popliteal arteries.
That's right.
You didn't even leave the intra-abdominal abdominal vessels also, celiac trunk, superior mesenteric, everything. Overall, wonderful presentation. You gave a wide array of the use of these IVs and OCT in various peripheral vascular interventions as well. I have one question in my mind. Usually the catheters what we use is about 20 megahertz catheters. Do you have catheters which are available lesser than that? Below, like you showed 8 to 10 megahertz catheters. Is it available
So
in?
for yes, for Boston do have the peripheral IVUS catheter available with them, so that can be used for say TVAR and EVAR cases.
Okay, okay. Because the use of these catheters, particularly in finding out the entry point of a dissection, I think it will be a great like use of these catheters, IVUS catheters.
Yes, that's definitely of great use, especially when we are struggling to find true versus false lumen in aortic dissection cases.
And you also have started your newsletter on the use of imaging. I think it's a very useful one. I think please
Thank you.
continue the same thing, whatever you've been doing. A great job. 75
Thank you.
international publications is a great achievement for anyone.
It's an old CV of mine. By now, I do have 135.
Oh God.
So,
and
hi
I've been
Tom.
seeing, and I've been seeing that you've been publishing it in very good international journals of imaging. I think even in
Thanks.
19 as well as in 2020 also you've published in good international journals. And very good pictures, very good picture quality, and easily understandable the etiology. I think that made the lecture very interesting. Thank you, Dr. Rajesh. I
Thanks
have
for the opportunity.
yeah. There is one question from Dr. Sudhakar Rao. He is asking, can we safely use coronary IVUS catheters for carotid assessment? What is your opinion about it?
No, see, one limitation with the carotid intervention is you have to have a limited amount of time to do the intervention. So thing is that with the limited time, you have to complete the procedure, and in case you are going to use the IVUS, though it can be used, but then you have to put your distal protection device further distally, because a 30 millimeter of IVUS catheter is going to protrude distally before you can imagine the bifurcation of common carotid artery. And therefore, too much distal placement is somewhat cumbersome, and then it's going to take too much of the time, where in carotid you just want to come fast and come out without losing the time. Other thing, with too much of manipulation across the high grade carotid stenosis, there is always a risk to have peripheral embolism and incidence of stroke. Even after the use of say distal protection device, you do an around 2% incidence of stroke, which possibly may increase with additional use of say intravascular imaging. So therefore, it's preferably avoided. What I quoted two studies, the one where they have done carotid and arthrectomy, taken out the carotid plaque and evaluated with the OCT outside. So it is not in vivo in vitro study of this plaque to look for what is the composition of. So this is the limitation of using the intravascular imaging for say carotid stenting.
I think it was a very useful tip that you have to be extremely careful, particularly in carotid interventions for the risk of stroke. Do you have any experience of using these imaging techniques in the femoropopliteal lesions, particularly like going into the true lumen, false lumen, and guiding, looking at the patency?
No, I personally don't have any experience of using it for say iliac and femoral popliteal lesion. But I feel instead of say iliac and femoral, it's a infra BTK lesion, where the sizing of the balloon and also the stent is important. It is more like say 4 or 5 millimeter size of the vessel, where the clinical outcome is going to be different when you have used the imaging and optimizing the result across this is the site where it is of more useful compared to say aortoiliac and the femoral for percutaneous intervention. That's my personal opinion about, and in near future I think we will be able to know about that. Imaging is going to be more useful for BTK intervention when the size of vessel is say 4 on 5 like we do have for the coronary.
Thank you, Dr. Rajesh. I don't think there are any more questions which are coming. We really enjoyed your talk. It was a very challenging and a very innovative talk. I've not
Thank
heard
you.
this type of talks anywhere. I think this is the first time I'm hearing such a talk by an expert operator. And I think your field of interest is probably imaging, coronary imaging. That's really good, doing a great job. Please continue with the same. Thank you very much. Thank you for being with us. With this, we will go on to the next talk. Our handsome cardiologist, Dr. Tom Devasya. He'll be now. We'll be going to the interesting case sessions. He's going to tell us about an interesting case sessions about thoracic and aortic aneurysm, TVAR and EVARs together, balloons everywhere. This is what I thought. Interesting topic. Now, Dr. Jenny will be briefly telling about introducing Dr. Tom Devasya to the audience. Dr. Jenny, please.
Thank you, sir. As sir had said, our next session is interesting cases and nightmares in peripheral interventions. For this session, Dr. Damodaran,
will be the moderator.
the senior consultant in cardiology working at Apollo Hospital at Chennai, will be the moderator.
Thank you. I'm here. Hello, good morning. Am I audible?
Hello, Dr. Damodaran. I can see you.
Audible?
Welcome to Saphire.
Yeah.
Thank you. Busy Sunday, we are troubling you to join us for the discussions.
Thank you.
Can you hear me?
Yeah, I can hear you.
Okay.
Am I audible? Yeah. Am I audible? Hello.
Our first case.
Okay.
Our first case will be presented by Dr. Tom Devasya. He is a professor and head of department of cardiology, presently working at Kasturba Medical College at Manipal. His expertise is in coronary angioplasty and stenting, IVUS and OCT, and rotablator guided PCI, peripheral angioplasty, device closures, dialysis fistula, interventions, to name a few. He has multiple publications, more than 50 publications in national and international journals. He is a principal investigator in various internationally funded research projects. He will be presenting an interesting case titled Balloons Everywhere, Combined Thoracic, Abdominal, Aortic Aneurysms. Over to you, sir.
Thank you very much for your kind words. Good afternoon and warm regards to all of you. From Kasturba Hospital, Manipal, Department of Cardiology. Please let me know when you can see my slides.
Yeah, we can see your slides now. It's getting uploaded. Yeah, we can see it now. It's seen clearly.
Thank you.
Thank you.
So I have been asked by Dr. Subramaniam to present a case of combined thoracic and abdominal aortic aneurysm and the management. So we'll start. Now I'm presenting to you a sample case of 62-year-old gentleman who has been a non-smoker, whose baseline creatinine was 1.6, who has been hypertensive on nebivolol and amlodipine, with history of post-PCI to left anterior descending artery and right coronary artery in January 2018, and has been on aspirin, clopidogrel, and rosuvastatin. His routine ultrasound abdomen showed infrarenal abdominal aortic aneurysm, so a CT aortogram was done. So in the CT aortogram, we had two problems. One was the thoracic aortic aneurysm, and the second problem was the abdominal aortic aneurysm. We'll take each problem one by one. this 3D reconstructed image of a CT angiogram, you can see that there is a fusiform thoracic abdominal aneurysm where the blue arrow is shown with a maximum diameter of 70 millimeter at the greater curvature of the proximal descending thoracic aorta. It is very important to note the location because it is a very tricky scenario because it is at the arch, at the bend, and at the greater curvature. And it was very close to the orifice of the left subclavian artery. And also there is also an infrarenal abdominal aortic aneurysm measuring about 58 millimeter. So both these cross over the cutoff values of 5 to 5.5 centimeter, beyond which there is increased risk of rupture. You can also see that there is an acute angulation of the aorta here, which will make the stent graft mobilization difficult into the thoracic aorta. So our plan was to do a TVAR, and here we were planning to land our proximal stent graft within the zone 1 because the aneurysm was extending beyond zone 3 proximally, and there is very little landing zone. So we had to land it in zone 1. And the problem is there are two important arch vessels, the left subclavian and the left common carotid originating from this zone, which once we jail, there will be compromise to distal blood supply. So we had to make sure that the blood supply is not compromised. And also after the stent graft is deployed, then these arteries should not act as feeding vessels to the aneurysm so as to cause endoleak. So we proceeded with an hybrid procedure. You can see that in the morning session under GA, the surgeon performed the right to left common carotid graft and the ligation of the left subclavian artery, which was immediately post-procedure without coming out of GA. We did an angiogram and checked the patency of the Dacron graft to either side of the carotid, to either carotids. And then we proceeded with a right femoral access. We did a aortogram through a 5 French pigtail, and then an extra stiff Lundquist wire was inserted to the right common femoral artery into the ascending aorta, and we passed a Valiant thoracic stent graft 44, 44, 50, the measurements which are based on the CT angiogram values, and advanced to the target site. Now our problem was because of acute angulation in the aortic arch, the stent graft could not be tracked over the stiff wire and it continued to collapse repeatedly into the aneurysm segment. You can see that as we push the stent graft forward, the graft gets buckled, this part gets collapsed into the aortic arch aneurysm segment, which actually increases the risk of rupture on table as well. This would be the course, the blue line would be the course of the stent graft that we anticipate so as to have a smooth delivery of the stent graft. Now, what are our options? Our options would include a snare-assisted pull-down of the delivery system, either by a transseptal or a transbrachial access, or you can externalize the transseptal guide wire and then have a loop and then help in the forward pushability of the stent graft, or you can have a more aggressive and invasive transapical approach by the cardiac surgeon, or we can have a balloon supported passage. What we did, we had a right radial access. We used a 25 millimeter 6 French snare, and the stiff wire was snared near the right innominate artery takeoff, and the angle of the wire was changed by the snare, enabling the stent graft to move forward into the ascending aorta and avoid collapse into the system. So we went like this. The snare was there, the wire was snared, and then it was pulled and pushed so that the collapse into the aneurysm segment was negated, and then the stent graft could move forward. once the stent graft could move forward, this prolapse was not at risk anymore. We could deploy safely distal to the right common carotid artery takeoff. This is the video. You could see that as I tried to advance every time, there was only buckling and prolapsing of the stent graft, whereas once I snared and then I did a pull and push technique, then I could push forward the aortic aneurysm. This is a common problem we'll come across if at all the aneurysm segment is located at the arch and the greater curvature is having the aneurysm. This problem is frequently encountered. So finally, we did a good deployment of the stent graft, and this is the final angio. You can see that the aneurysm segment has been properly covered, and this is the 3-month follow-up by the CT angiogram, and you can see that there is no endo leak. The stent graft is sitting perfectly well, and now we have the next problem, that is the infrarenal abdominal aortic stent graft to tackle. So from the problem management that we have done for the thoracic aortic aneurysm, the take-home message would be the TEVAR has become the preferred technique for treating thoracic aortic diseases, replacing operative management as conventional mode of treatment. Even in cases involving aortic arch, TEVAR has evolved as a preferred technique using the hybrid procedure where the vascular surgeon will help us to maintain blood flow into the major arch branches. In case of difficulty in tracking the endovascular graft through the arch due to various reasons, simple options like transradial access and snare method can avoid other cumbersome and complicated options. This is the first time a transradial snaring has been reported. It was not been seen in any of the publications yet. Most of the times, the snaring was done by contralateral femoral or brachial approaches. Now coming to the problem 2, the abdominal aortic aneurysm. This was again the review of the patient's history. Even though he had been a case of polyarteritis nodosa, we believe that this aneurysm is related to atherosclerosis. And this patient had a mural thrombus in the infrarenal abdominal aortic aneurysm, and we had proceeded to management of infrarenal aneurysm after 6 to 9 months after the repair of the thoracic aneurysm. So this is the CT angio and 3D reconstruction of the patient prior to the abdominal aortic aneurysm repair. And we had planned EVAR. This is the video of various, and you can see that there is a fair amount of landing zone distal to the renal artery where there is normal segment. So we did a bilateral femoral cut down with the help of our vascular surgeon, and we placed the stent graft over a super stiff wire and confirmed the renal arteries are not compromised. You can see that the main limb and the right iliac limb of the stent graft being deployed, and on the right side the nose cone is being deployed, confirming that the renal arteries are not compromised. We do a check angiogram to confirm that the stent graft is well positioned, and then we go to deploy the contralateral limb of the aortic stent graft. This is the continuation of the stent graft deployment. This is the deployment of the contralateral iliac limb with appropriate overlap of the stent graft so that there is no chance of leak. This is the final result. You can see that the renal artery flow is compromised and the stent graft has landed proximally and distally in normal zones, and The take-home message would be simultaneous surgery for the treatment of multiple aortic aneurysms is theoretically desirable. However, the high invasiveness involves a high risk for the patient. As an alternative, staged surgery is undertaken in majority of cases to minimize the surgical risk further. An endovascular aortic repair has been aggressively introduced and has become one of the routine procedures for the treatment of aortic disease presently. The hybrid procedure combining conventional surgical approach and EVAR implemented simultaneously or sequentially is effective for the treatment of multiple aortic aneurysms and is likely to reduce or minimize mortality and morbidity. Thank you very much.
Thank you, Dr. Tom. Am I audible?
Yes.
Yeah. It's an excellent presentation. I would say, first, I would like to congratulate you for being the first case in the world literature for doing it through the radial route. You've done an excellent job. You have planned your procedure very well and executed it also very well. Everything stepwise you have done. Initially, you have done a grafting between the two carotid arteries, and then the placement of the grafts was excellent. And then subsequently, you taken up EVAR also. Overall, it was a very good case. And now I invite Dr. Damodaran. Dr. Damodaran, are you there?
Can you unmute yourself, please?
Am I audible?
Yes. Yeah. Dr. Damodaran, you are audible.
Hi, Subramani. Hi, Dr. Tom. Very nice to see you on this relaxed Sunday to learn more about peripheral interventions, which is usually now taken over by our colleagues, vascular surgeons and vascular interventional radiologists. Still, we are fighting to have our share. And in fact, I am very amazed by the kind of work you have done, that the hybrid strategy for a thoraco-abdominal aneurysm, more of a thoracic and abdominal as a two distinct entity. And in an excellent case, I think Subramani could recall that when we did the first of, Dr. Said did the first of its TAVI with a very bulky core valve, we could not negotiate the aortic arch. That's what you have also encountered here. You very nicely, predicted that it is going to be the problem. You have taken a right radial approach and put a snare and do it. We also did the same thing. It was when you negotiate it or advance through the aortic arch, which is more angulated like here. It's a very cumbersome procedure, and to negotiate across the arch into the ascending aorta is really, you need all the technical skills to negotiate. You have done very nicely, and you have showed the other ways like transeptal axis also as an alternative thing. My question here is like, no, you have done a very good job, like a hybrid one, but which of the cases you can think of, though you are telling theoretically a hybrid procedure, you can think of doing a same sitting rather than, still I advocate to do a staged one because of whatever the technical things you can demonstrate in a single stage. Obviously, being a human biology, we can have post-implantation syndrome of doing two, grafts at the same time, the procedural time, so many things. Of course, which of the cases do you think we can do it in a single stage? Number two, which of the cases you can take a prophylactic spinal drain? Suppose if you are covering the left subclavian without a carotid bypass or left carotid subclavian bypass, which of the cases? Just for the audience and those who are interested, obviously you are a master in that, but still I want you to. And one more small doubt, maybe on the slides you showed, just above the renal level, the aortic segment is not that much dilated, isn't it? Though it looks like somewhat dilated, but it is not meeting the criteria to come up to the aortic level. These are the three doubts I have, but otherwise an excellent case, and really have demonstrated the skills. Thank you so much.
Thank you very much. So regarding why we staged this patient had a baseline creatinine of 1.6, and we thought that the too much of contrast usage in one sitting may not be very favorable for him. And also this patient had a thoracic aortic aneurysm that was more than 7 centimeters, and the infrarenal abdominal aneurysm was close to 5.7 centimeters. Even though they both actually met the criteria for repair. I thought the thoracic aneurysm being the larger between the two and the more difficult one. Frankly, we were really exhausted after trying all these tricks for at least 3 to 4 hours to negotiate the stent graft, and I thought it is not at all a good choice to do simultaneously in the same setting. And also it makes sense to give some time, do repeat CT angio at 3 months or so, and make sure that there is no endo leak, because it is relatively easy in case I want to put one more stent graft in the thoracic segment. I need to make sure that there is no significant endo leak on a follow-up CT, and it is easy for me to track one more stent graft through the elastic iliac and abdominal aorta than trying to push another stent graft which is relatively bulky through the not so elastic stent graft segment of the abdominal aorta. So looking into all these things, I usually prefer to do a staged procedure, and I feel that it is more or less safe, except in situations where we will come across, thank God I have not had such a situation, that we will come across both thoracic and abdominal aortic aneurysms, where the abdominal aortic aneurysm is quite big and it is maybe more than 7, 8, 9 like that, and with symptoms, and you also have a thoracic aneurysm, then it is quite a dilemma to choose between which one to do first, because of the large impending chance of rupture of abdominal aorta, you may have to do that first. And then if you also have a thoracic aneurysm, then you will have to pray very well before you decide to track another stent graft through that and deploy it in thoracic aneurysm. And especially if you have the aneurysm in the greater curvature of the arch, then you are going to be in real trouble. So thank God we have not come across such a case so far, but I hope I don't.
Thanks. Thank you.
Thank you very much.
Thank you, Dr. Tom. It was a wonderful presentation, and there are a lot of good messages here. A lot of messages. You have really done the procedure very well, and then demonstrated your technical skills as well. All right. Thank you, Dr. Tom. Dr. Amodan, any more questions do we have?
Yeah, it's a wonderful, because we can ask so many questions, but this is the one of the rarest kind of cases, and so he emphasized the role of staged procedure. That is what we have to take it as a take-home message. Yeah, that is.
Take-home message.
Yeah.
Can we go to the next talk now? Dr. Sudhakar Rao will be presenting. Thank you, Dr. Tom.
Thank you.
Yeah, I will mute. Okay.
Thank you, sir. Next, we have Dr. Sudhakar Rao, Associate Professor in Department of Cardiology, presently working at Kasturba Medical College at Manipal. He has around 50 publications in peer-reviewed journals, awarded the best case presentation in CHIP CTO 2020, also the best case presentation in IHRS 2020. His areas of interest is imaging, AV fistuloplasty, carotid intervention, and clinical cardiology. He will be presenting an interesting case titled Nightmares in Carotid Stenting. Over to you, sir.
Welcome, Dr. Sudhakar. Can you hear me?
Yes, sir. Am I audible?
Yeah. How are you feeling now? You're fine?
Yeah, I'm better, sir. Yeah. I'll share my screen, sir.
Yeah. Please share the screen. Yeah. Yeah, we can see your slides now.
Yes.
All right.
So I would like to thank the organizing committee of Saphire 2020, especially Dr. Subramaniam sir, to give me an opportunity to present today on this platform. So I'll be presenting a few cases on a complex, few complicated, and few which became complicated carotids. And these are the not the normal ones as the sir discussed. We do not discuss the peripheral interventions and their nightmares beyond the corollaries too much. So I thought we'll discuss few of them today in this symposium. There are no conflicts of interest and nothing to declare. Before I go to the core presentation, I just wanted to highlight, because this is the basis of this carotid stenting and carotid endarterectomy. Over the last 1.5 decades, the scenes in the carotid procedures have changed. We have evolved from medical management to carotid endarterectomy and now to carotid artery stenting. So the latest trials based on many RCTs and meta-analysis and the current ESC and ACC guidelines which have come, as we all know, there are definite indications where carotid stenting has their own role, like patients with multivessel disease, severe LV dysfunction, patients with radiation-induced carotid stenosis or difficult neck and neck arch neck vessels, or patients who underwent restenosis after a carotid endarterectomy. So these are the definite indications where there is a role of carotid artery stenting. However, there are other indications where we have to compare the risk between the endarterectomy and the carotid stenting, and this is where the role of carotid stenting is been coming up. So if we are in a patient who is average surgical risk or a low surgical risk, if we are able to do a carotid artery stenting with the anticipated risk of peri-procedural stroke and mortality less than 6%, then it becomes a class 1 indication even for a carotid artery stenting. However, there are fewer areas like asymptomatic carotids which still are not well established in the literature. Now, before going to the cases, what are the common complications we face after a carotid stenting? It can vary from the excess site complications to the hypotension and bradycardia, which we know is due to the balloon dilatation or post dilatation, or during stenting the carotid sinus gets and the baroreceptors are activated. It can be taken care well by giving a 0.5 to 1 milligram of atropine, which can prevent the sudden decrease in the BP. However, care should be taken in the elderly patients where they can develop sudden restlessness and all. Also, we can encounter complications like dissection. If you do aggressively post dilatation at the edge of the stent, we can land up in a dissection. Distal ICS spasm are quite common due to the debris or thrombus, and can be taken care by giving nitroglycerin post procedure. Slow flow is one of the things which I would like to discuss today in my cases. And then we can have complications like cerebral embolism, TIA, or stroke, which are though commoner than other complications. And very rarely we can have hyperperfusion, which can last in only 0.2 to 5.5% of cases, and they can be devastating complications. Apart from that, to intervene, there are cases like the tortuous carotids, or we can have cases like a blindness following a carotid stenting, which I'm going to discuss. So this is the case one, a 73-year-old female hypertensive with a normal LV function, history of permanent pacemaker implantation in 2006 for a complete heart block. Left hemiparesis of 3 days duration, and she had a right MCA infarct on CT. CT angio showed significant right carotid artery stenosis, and she was planned for a conventional angio. She had a single vessel disease with a right IC. Right IC had 90% stenosis. There was a 360-degree tortuosity after the lesion. Luckily, there was no problem in negotiating the stent, but there was a problem in putting the filter. So she was planned for a stenting in the following week. So this is the angiogram. This is the AP view showing the lesion. You can see the hazy lesion. The lateral view I have not available. So you can see we put the TPI backup and the 8F JR guide into the common carotid artery. The cyan blue wire was progressed through the lesion. And you can see the 360-degree tortuosity and the spider effect 6 mm filter was easily taken through this. However, when during the deployment of taking the filter through the tortuous place, it was difficult. So there are many options which have been implicated in this. Like what we did is we have done the swallowing movement. Patient was having a continuous swallowing movement, and with the slight extension movement or the neck movements and manipulation, we were able to take the filter just beyond the tortuosity. Following this, the filter was deployed just above the level of tortuosity, and the lesion was dilated with a 3.512 NC balloon at 10 atmosphere. And a 6840 protease self-expanding stent was deployed. There was not much waste. Waste was around 30 to 40%. However, while retrieving the filter, there was little manipulation. The guide was coming up. However, with the careful we were able to retrieve the filter, and this was the final flow. And there were no other post-procedural complications and all. So most of the cases we do. There can be a tortuous carotid, and with the movement like the manipulation and the swallowing movement and the neck turning, we may be able to get away. However, is it possible to avoid a filter? No, I don't think so with the current recommendation, and it is very riskier to do any carotid procedures without a carotid filter. People have also tried harder wires like a grand slam, where after crossing through the tortuosity and waiting for some time, the tortuosity may disappear sometimes. People have used proximal protection devices like the Medtronic's Momo and the other Roadstar. However, in India at present they are not available. They need a larger sheath, 9F sheath, and they need a non-occluded external carotid artery because it prevents both the antegrade flow and the retrograde flow through the ICA. And so if your external carotid arteries are small, like a 5 or 4 mm, it is difficult to use this proximal protection devices, and they do have other complications, get dissection and other things. People have used double guide wire for a support, and even a dual guiding catheter for support. Now I'll go to the case 2. This is a case of a 68-year-old female with a diabetic hypertensive, and she had a history of abdominal aortic stenting and LAD PCI in 2014. She had a history of left upper limb weakness 10 days back and a normal ECG and a good LV. She was planned for an angiogram after the Doppler and a proximal RCA showed subcritical CAD with a patent disc in LAD. This was her carotid angiogram, showed a right side tight at 90% and even a bilateral carotid stenosis. Being an old female and a history of abdominal stenting in the past and other comorbids, they decided to go ahead with the carotid stenting. So this is how this carotid was hooked and passed. Cyan wire was passed, and 6840 protease self-expanding stent was used after deployment of a 6 mm spider FX filter. So this is how the filter was retrieved, and this is the final flow after the carotid stenting. Next day of the procedure, the patient complained of decreased vision in her right eye, which was decreased almost to 80% of the normal, and the repeat CT did not show any new infarct or a hyperperfusion evidence. We suspected a branch or a central retinal artery occlusion and obtained an ophthalmology opinion, and a diagnosis of central retinal artery occlusion was made. We went through and reviewed our angiogram, which actually showed the ophthalmic artery branch was missing. However, it was too late, and beyond 6 to 12 hours, it would be difficult to go and do a local thrombolysis into the branch. So a re-intervention was not possible. She was discharged on timolol, acetazolamide, and other supportive measures. However, she came for follow-up 3 months after, where her vision was restored to 50% of the normal. Now, this is one of the though less than 1% cases. Only some 10 to 12 cases have been reported in literature. As we know, the ophthalmic artery occlusion can be because of a thromboembolic or embolic phenomena. However, central retinal artery occlusion is mainly because of embolic phenomena. Because one mechanism is that the internal carotid artery gives rise to ophthalmic arteries, and therefore ICA stenosis may result in insufficient blood supply to the retina. In carotid stenting, due to various procedures like pre-dilatation, post-dilatation, filter, taking up of the filter and stenting, the debris may go to these vessels and cause embolic phenomena. There is one more mechanism which has been told is there has been the anastomosis between the ophthalmic artery and the external carotid artery. Now, the ophthalmic artery has numerous extraorbital branches which can extensive anastomose with the internal carotid artery. And during any of these steps, like taking the stents and all, this anastomosis may cause retinal embolization. Now, I reviewed the literature. Apart from this, there has been 2 cases which are also reported of blindness following a carotid stenting, and this is known as an ocular hypertension syndrome. This is very rare event and should always be considered if a patient develops blindness at the same day or 24 hours following carotid stenting. As we all know, carotid revascularization may restore the cerebral perfusion pressure and improve the intracranial hemodynamics and improve ocular circulation. However, severe carotid artery disease with poor collateral circulation can predispose to flow reversal in the ophthalmic artery. And this is one of the very important findings, the flow reversal in the ophthalmic artery causing ophthalmic artery steal syndrome. Now, the secondary chronic ophthalmic artery insufficiency and resulted retinal ischemia and choroidal hypoperfusion can cause the neovascularization in the iris, which can cause the adhesion between the iris and the cornea, causing the closure of the anterior chamber. And this causes the decreased reabsorption of the aqueous humor. Normally, initially, the reabsorption and the production of the aqueous humors are matched. However, following carotid revascularization, there is a sudden hypertension and increase in the aqueous humor production by the ciliary body, and the resorptive capacity remains low. So this imbalance can cause something known as a neovascular glaucoma, which can occur immediately 24 hours, and the patient may have blindness. So I think this is one important thing which should always be kept in mind beyond the normal cause of central retinal artery occlusion following a carotid stenting. Now I'll go to the third of my case. This was a 44-year male with a null comorbids and a right hemiparesis 2 weeks back. The left MCA infarct on CT. ECG and echo were normal, and the CT was suggestive of left ICA stenosis. So this was the left ICA stenosis. We put a 6 mm spider FX filter after taking the through the sorry. So this the lesion was dilated with a 3.5 12 NC, and you can see this there was a no reflow. Even without post dilatation, we had a no reflow. Now we know this no reflow is most commonly because of the post dilatations of the stent, and many articles they have told that post dilatation is not a step which should be done definitely, because if you can get away with a 30% residual lumen diameter, a post dilatation is not much. However, after the CREST and the Saphire trial, which have told that 66% of the reef stenosis can happen if you don't post dilate, the post dilatation capacity had increased. However, in the last few years, many other trials had come which have showed that the post dilatation doesn't add much. It can add to your acute complications like a hyperperfusion syndrome or a microemboli or a TIA or a newer stroke or a no reflow. So we tried taking first the thrombus aspiration. However, it was difficult to negotiate the thrombus aspiration catheter. So thinking that the debris was lodged in the filter, we removed the filter, and then we so that there was a good result. And then one more case of a 60-year-old male with a diabetic left hemiparesis, right ACMCA infarct with a normal ECG and echo with a mild CAD. The CT angio showed a right ICA stenosis, and she was planned for a revascularization a month later. There you can see a tight right ICA stenosis, and a filter was deployed, 6 mm spider FX filter, and post dilated and pre-dilated with a 3.515 NC. Again, we had the same thing after the stenting with the 6840 protease. The patient had no reflow. Here, what we did is we took a thrombus aspiration over the same wire, the filter wire, and the thrombus aspiration was done, and then the filter was removed, and you can see a good flow. Now, no reflow after carotid stenting remains one of the less described and important complication. The most common reason, as I told, being a post inflation of the stent. Sometimes spasm in the distal dissection may be the reason. However, most common is the thrombus and the debris. Ideally, should do a thrombus aspiration before the filter retrieval to prevent any distal embolization. And the role of GP2B3A remains a controversial as many and may cause other unwanted complications. The role of post dilatation remains controversial and remains the operator's choice, except the restenosis versus the peri-procedural stroke risk. So these are the few cases of carotid which I thought I will get into the light. Thank you.
Thank you, Dr. Sudhakar. Thank you, Dr. Sudhakar. It was indeed a great presentation of the 4 interesting cases. You have done all the procedures very well. I have my own doubt regarding the post dilatation, because I do it as a routinely in all the cases. I prefer to do a post dilatation.
Yes.
Another one thing, new thing, what I have learned is about the ocular hypertension syndrome. I think I have to go into the literature to read more about this. I've not heard this earlier. Dr. Damodaran, would you like to give
Yeah.
any comments?
Yeah, it's an excellent collection of carotid stenting complications. Really, I have learned, as Dr. Subramani told, the ocular hypertension syndrome from you. Thank you so much. But as he rightly mentioned, nowadays the concept is more moving towards pre-dilatation rather than post-dilatation. I think Subramani could remember when we used to do stenting along with Mathur, we usually put a stent straight away without a pre-dilatation, then we will do a post-dilatation. Of late, all the data showed in favor of pre-dilatation, and we can very well accept, as Dr. Sudha told, that the 30% of residual is okay. Even when the trials like Saphire and others told the long-term outcome in terms of restenosis, but one can definitely weighing over the acute complications over the long-term stenosis. When there is acute complication, we will be in trouble and a lot of stress. So the pre-dilatation is usually my strategy in these days. And I usually go up to 4 millimeter balloon, not beyond that, because most of the carotids will, will accept that. And the second thing is, like the first case, he has shown the technically very challenging tortuous carotid, where he suggested a Saphire. Obviously, the Saphire can, overcome this problem. And definitely, and the Saphire, you can take the devices stent very easily. And sometimes, if the one of the few occasions where I did the post dilatation, even with a reasonable post stenting result, say less than 30%, when we are taking the retrieval catheter, it may go and hitch the proximal strut of the stent. So in that case, I used to just oppose the proximal strut of the stent with the post dilatation. Otherwise, most of the time I can avoid post dilatation. This is one thing. Yeah. Then there is a tortuous lesion. Obviously, maybe his stenting result was excellent, but few of the cases I observed there is a pseudo lesion due to the accordion effect. So we must be very, very aware that it is a pseudo lesion. Unless there is a flow disturbance, we better should, leave the pseudo lesion without going on chasing. I have seen few of the case presentations in the previous forums. Some of the forums, they put chasing the pseudo lesions by putting another stent, all those things, that we should be aware of that. And regarding the neuro complications, second case is learning to me, and definitely this is a new entity apart from the embolic complication. We also should have one case like when we did the pre-dilatation, patient went in for a kind of slowness of speech. We thought he is going in for a minor stroke. Then immediately finished the procedure. We took for a CT. CT didn't show any of the embolic material or any infarct in the brain. So we also should be aware of this TOTS paralysis. That is the transient occlusion of the cerebral circulation can cause a temporary neurological problems, which mimics like a minor stroke. That is also that entity I also learned after doing that case. So obviously we should not have any hesitation in calling our neurological colleagues, neurointerventionists. They will be of very helpful in immediately shooting the cerebral circulation to find out whether there is any problem in the intracranial circuit. The no reflow is the one of the dreaded thing of all these complications. Other complications, the no reflow is most of the times it is due to the mug which is going at clogging the filter. Most of the times, if you do a good thrombosection, it will obviously relieve the flow. But sometimes there is Dr. Sudhagar told, there is a dissection, or sometimes you can have a generation of a new thrombotic material in the main ICA. I have seen one of my neuroradiologists when he was doing that. He did a thrombosection. Still, that flow was not. Then he was doing a shoot. Then he found out there is a huge thrombus beyond the stent. Then he did a lot of thrombosection. Then he had to put another stenting to bail out the case. And of course, there were some spillage of the embolic material into M3 and M4. He didn't do. He didn't bother about that. He didn't retrieve it intracerebrally because it was very distal. But we people won't do it with very much skepticism, but neurointerventionists are giving intracerebral 2B3A. I was the first time I was surprised and shocked to see he was giving very casually. Then, like how we deal with the coronary, they are also giving So there are controversial data on that, but they believe that the neurointerventions are giving the intracranial that to be 3A also. So no reflow is obviously one of the very dreaded complication, and luckily in your case it was like more of a clog material within the filter. Once you remove the filter, it became all right. Anyhow, overall it is a very good collection of cases. I really enjoyed it. Thank you so much, Dr. Sudhakar.
Thank you, sir. Thank you, sir.
Yeah, thank you, Dr. Sudhakar, for a wonderful presentation and your collection of cases too.
Thank you, sir.
Now, we'll go to the next, the last talk of our session today. Dr. Ashwal will be presenting about the hybrid procedure technique in peripheral interventions. Dr. Ashwal has been a very young and very active cardiologist who's been working at CMT Manipal. So Dr. Jenny will be introducing Dr. Ashwal. I think Dr. Ashwal is taking some time to join us. Some technical issues are there. Okay. It's a small technical snag by Dr. Ashwal. He's trying to rejoin us again. Dr. Damodaran, like you have been doing quite a lot of coronary as well as peripheral interventions in Apollo Chennai. I think you also successfully conducted these CHIP CTO conferences there for the last many years. You've been doing the most complex cases and have been doing a very good job. This year also during the COVID time, you have done a webinar. What is your experience about this no flow phenomena? What you see in the carotids? Do you also find it frequently to see this type of things happening by doing carotid angioplasties?
Carotid, yeah. Obviously, carotid, first of all, let me admit honestly, as you rightly told, I am doing reasonable number of complex coronary, but our institution is in such a way, they have compartmentalized all the interventions. Like carotid means even if we are going to do, we will keep, because we got reasonably trained in escorts, but so even if we do, we have to keep our neuro interventions by the side. So it's more of a teamwork there. Unlike the previous hospitals where I worked, I used to be the lone soldier. Here it is not. We have the comfort zone. He'll be by the side when we are doing everything. Then he will be also helping us. So some of the cases, even if it is not my case, it's a neuro intervention. We used to go out of interest and see. Such one of such cases, obviously, when he encountered a few cases when he aspirated the thrombus from the filter with the usual coronary thrombosuction catheter, went on very well. One instance when even after repeated suctions, we could not get a flow. Then we thought that it could be a distal dissection or a thrombus. When we did a mild balloon dilatation, still it was not clearing up. So it clearly showed even the tagging with the balloon didn't yield. That means it is not a mere dissection. That might be more of a thrombus. So then he did a thrombosection and obviously he put another stent. Then it got cleared. But unfortunately, some bit of thrombus went into the cerebral circulation, but it was more of a distal thrombus. So few cases I have watched about this. But anyhow, we should always think of the simple reasons, like it could be a spasm or a dissection. So we give a lot of vasodilators immediately. If the BP is allowing, then we'll go and tag with them. We will try to suck the clogging filter, and even after that, even after removal of the filter, if the slow flow is there, then we need to put a balloon and do a little tagging to see whether it is only a dissection or a huge thrombus. If it is a huge thrombus, it is the hell of the day. Then you have to literally clear the mug, and then you have to put a primary stenting of the coronaries. Even in some of the de novo stroke cases, I have seen which involves the internal carotid artery. After doing a shoot, he does a primary stenting of the carotids. After doing thrombosection, he do a primary, because internal carotid artery is such a huge artery which may not yield to simple thrombolytics like intracranial or regional thrombolytics. So unlike the middle cerebral artery circulation, where I have seen him doing both intra-arterial lysis as well as thrombectomy, whereas here it has straight away a thrombosuction and followed by a primary stenting. So primary stenting of a very good role in internal carotid artery stroke or internal carotid artery thrombosis. That's what I have learned from our colleagues, neuro colleagues also. Yeah. Hello. Subramaniam? Hello? Hello?
Yeah.
Dr. Subramaniam, can you unmute? Okay.
Yeah. Dr. Ashwal has joined us. Dr. Ashwal, are you ready? Any? Dr. Damodar, which is your preferred vasodilators in carotid stenting? The same vasodilators what we use in coronaries? Do you use the
We
same?
usually, being cardiologists, we usually give this, but I have learned from neurologists they are giving sometimes nicardipine and other kind of things also.
Okay, okay. Nicardipine also there is? Okay.
But for us, it is a new thing. Only theoretical, we usually give this nitro, but sometimes, immediately after stenting, the BP hemodynamics may not allow you to give push much and nitro and other things also. And one other thing I just want to ask from the speaker as well as from you and the other panelists, like, are you prophylactically keeping temporary pacemaker these days, or in which of the situations you will keep the temporary pacemakers and before stenting, and or you can manage only with atropine whenever necessary?
No, as a protocol,
till the other speaker comes for presentation. You can call Sudhagar and Tom, and so that we'll have some discussion till this.
Hello.
Yeah, Dr. Ashwal. Dr. Ashwal, welcome to our conference.
He is ready.
Sorry for all the trouble. It is because of
no issues.
Glitches
we are all waiting for your talk.
Yeah, shall I share now, sir?
Yeah, just a second. Dr. Jenny will be introducing you to the audience.
Sure, sir. Sure, sir.
The next talk will be by Dr. Ashwal AJ, Associate Professor and Unit Head of the Department of Cardiology, presently working at Kasturba Medical College, Manipal. He has excellent exposure and versatile hands-on experience in all forms of PCI. His areas of interest is complex coronary interventions and cardiac transplant. He has multiple publications in both national and international journals. He will be presenting an interesting case titled Hybrid Interventions in Critical Lower Limb Ischemia. Over to you, sir.
Okay. I share now?
Yeah. Please share, Dr. Ashwal.
Yes, sir. I will be sharing now. 1 minute.
Dr. Ashwal will be speaking about an interesting aspect of the peripheral interventions, that is the hybrid procedures, where the surgeons and cardiologists work together in relieving this critical limb ischemia.
Are you able to see my screen, sir?
Yeah, we are able to see your slides.
Okay.
Yeah.
First of all, I would like to thank Dr. Subramaniam and the entire team of the organizing committee for allowing me an opportunity to present in this CME. Today's topic is hybrid revascularization for a critical lower limb ischemia. First, I will briefly explain about the hybrid revascularization. It is, as we all know, a combination of surgical procedures and endovascular therapy. It was first done in 1973, which involved PTA of the pelvic arteries with femoral bypass. Currently, it involves around, it constitutes around 5 to 21% of the total procedures. And the largest study of this hybrid revascularization for critical limb ischemia was presented in 1997 by Madeira et al. Why we need these hybrid procedures? This is especially helpful in elderly patients with high surgical risk and with a life expectancy of less than 2 years. It significantly enlarges the scope of treatment in patients who are associated with significant comorbidities, obesity, poor local skin conditions, and in the absence of suitable grafting vessels and poor distal revascularization bed or target vessels. Typical hybrid intervention involves the interventions aimed restoring the inflow and aimed at restoring the outflow. The endovascular therapy is usually indicated in inflow arteries, which are mainly iliac arteries. The studies have shown a high success rate, excellent safety, and a long-term patency of 80% in 5 years. Usually, the outflow lesions, which is common femoral artery and superficial femoral arteries, are dealt with open surgery, either by thromboembolectomy or graftings. And this has become an established surgical technique with a 5-year primary patency rate of 91 to 96%. The combination of these two treatment is considered very effective. The combination of thromboembolectomy, femoral bypass, and femoropopliteal bypass are considered typical methods, which are followed, which are together done with the endovascular therapy for iliac artery regions. However, distal bypass below the knee can be considered in critical limb ischemias. Endovascular therapy for SFA region has high success rate and low complications rate, outcomes for long-term patency rate, including drug-eluting stents and drug-eluting balloons. Another approach is for inflow lesions, open surgery, and outflow lesions is endovascular treatment. This typically involves aortoiliac or femoral artery bypasses with superficial femoral artery to the superficial femoral artery, and for below knee vessels endovascular treatment. Aortoiliac or femoral bypass, femoral artery bypass have demonstrated, as we all know, excellent results. And endovascular therapy for below knee arteries is in principle limited to only patients with critical limb ischemia. However, the results of BASIL trial are very much encouraging, and even the endovascular therapy is advised for lesions below the artery. Why the endovascular therapy for below knee vessels is limited to critical limb ischemia is because of the long-term results are not that good. Here we present 3 cases where we did hybrid revascularization. All the 3 patients had diffuse peripheral artery disease with critical limb ischemia. Here, what we did was a surgical revascularization with femoral or femoropopliteal bypass with the embolectomy of the proximal arteries, followed by PTA and stenting of the distal vessels, crural vessels. This was a 27-year-old female. She presented with pain and blackening of the second and third toes of the left foot for 1 month. There was not much significant past history. The CT angio showed the thrombus occlusion of the infrarenal aorta along with the proximal iliac artery on the right side. And distally, if you see the distal vascular bed on the right side, the anterior tibial artery was flowing. However, there was distal flow limiting lesions in the anterior tibial artery, and the common peroneal trunk was occluded in the right side. And similarly, on the left side, which was the limb she presented with pain and blackening of these toes, there was significant ischemia in both anterior tibial artery as well as the common tibiofemoral trunk. The surgeons did the excision of the floating infrarenal aortic thrombus and embolectomy even from the popliteal artery was done. And in view of the critical limb ischemia, distal revascularization was planned. What we did was, after the surgical procedure, patient was shifted to our cath lab, and with the help of the surgeons, the 6F sheath was directly inserted into the distal left SFA, and angiogram showed left popliteal artery distal occlusion with reformation. This was the angio. Here we can see that the distal popliteal artery is diffusely diseased, followed by left tibioperoneal proximal subtotal occlusion and complete occlusion of the anterior tibial artery. Here the common distal popliteal artery and the tibioperoneal trunk was crossed with a Terimo wire, and serial dilatations were done with Cook balloons, initially with 420 and then with 560 at nominal pressures. And the final angiogram showed good results in the common tibiofemoral trunk, especially the posterior tibial artery. The second case was a 55-year-old male patient with claudication of the left, both the lower limbs, but the more symptomatic limb was the left limb, along with the rest pain for about 2 years. There were no ulcers. He was a known diabetic with a history of smoking, and there was history of amputation of the left foot. This was the CT. The CT showed on the right side there was complete occlusion of the common iliac artery and reformation at the common femoral artery. And then there was distally the tibioperoneal trunk was completely occluded with faint distal anterograde flow in the anterior tibial artery. On the right side there was a long segment lesion in the SFA, followed by distal occlusion of the tibioperoneal trunk and anterior tibial artery. So the plan was to femoral bypass and left femoropopliteal bypass. Right side femoral bypass was done, and on the left side femoropopliteal bypass was done with SVG grafts, and patient was shifted to cath lab for distal revascularization of the left leg. And we did angioplasty, balloon dilatation of the anterior tibial artery and the tibioperoneal trunk. This was the angiogram which showed the anterior tibial artery flowing, however with the complete occlusion of the tibioperoneal trunk. There was diffuse disease in the anterior tibial artery also. Here the tibiofemoral trunk was crossed with cyan blue wire, and serial dilatations were done with the coronary balloons. And the serial dilatations were done till the distalmost part. And this was the final result with good flow in both the anterior tibial and posterior tibial arteries. Third case was a 62-year-old male patient, diabetic and hypertension. He was admitted with dry gangrene of the left second toe. This was the angiography. Sorry. It showed a long segment lesion in the SFA, along with complete occlusion at the distal end and reformation of the popliteal artery. And the angiogram also showed there was a diffuse significant disease in both the anterior tibial artery as well as the tibioperoneal trunk. Femoropopliteal bypass grafting was done. Patient was shifted to cath lab, and access was taken with the direct insertion of the sheath into the graft, and angiogram was done. Here we did the balloon dilatation of the common peroneal trunk and the anterior tibial artery. Both were good results, but after the angiogram was done and angioplasty was done, we found out that the distal part of the catheter, which was MPA, was broken and it was stuck in the distal popliteal artery. We tried to retrieve it with inflating a balloon distally, a higher size balloon, by passing snare, by passing two wires and trying to hold and catch the that fragment with two balloons and pulling up. Everything we did. But what happened was that the distal segment was broken and it got stuck there, and with complete occlusion of the flow distally. So then finally we had to remove it with the all attempts were in vain to pull that fragment. It came and got stuck till that proximal part of the popliteal artery. Then finally we could be able to bring it out with the help of endomyocardial biopsy. But after that the angiogram showed again dissection and complete occlusion of the entire popliteal artery and the distal vessels. Then we had to stent that popliteal artery with the coronary stents for 48 stents, 2 stents we used. Then finally we had a very good result in both the vessels, distal limb vessels. So take home message is complete revascularization can be achieved by hybrid procedures. It reduces the overall surgical risk and improved outcomes, because ideally the treatment would have been the femorocrural bypass, but provided the poor distal vascular bed, the question on the success of the such procedures, the mortality and the morbidity associated, we thought that a planned hybrid procedure where proximal lesion is dealt with surgery and the distal lesions are dealt with the balloon dilatation would be beneficial for these patients, and inadequate results of one approach can be supplemented by other. Similar in our patients, because we did the proximal surgical intervention, however if the distal flow was not good, the patient would not have been benefited much. So we tried to increase the distal outflow by balloon dilatation, and which we overcome the drawback of surgical intervention. Similarly, access difficulties can be easily managed. Here, getting access to the distal most vessels is very difficult, because our balloons and wires, we don't have the dedicated balloons or wires at our setup. As a result, it is very difficult for us to reach the distal most areas. However, in our case, we, with the help of the surgeon, we could access the distal popliteal artery or distal femoral artery or the popliteal artery under direct vision, so that we could easily take our balloons and wires till the dorsalis pedis artery. And it also reduced the surgical operative duration and the physical stress, and as a result of complete revascularization and minimal surgical procedures, it also decreases the hospital stay, risk of infection. Thank you.
Thank you, Dr. Ashwal.
Yes.
Am I audible now? Yeah. Thank you, Dr. Ashwal. It was an excellent collection of cases. You have done a great job. Even one of the patients, you had a complication of the retained catheter tip. That also it was managed in a different way, by your own way of using it, and by a kind of biopsy forceps, you're able to retrieve. Excellent job. I think for these cases, I think ideally what we need is a hybrid lab. Probably none of us are don't have these hybrid labs where both the surgeries as well as an angioplasty can be done together on the same table. Can you please stop sharing, Dr. Ashwin? I think can you please stop sharing? Yeah. Yeah. Thank you. Over to Dr. Damodaran for your comment.
It's a excellent concept, that hybrid approach, both doing a surgical proximal and distal balloon is a good approach. And let me just share my thoughts on coronary, because we are the first of its kind, almost done 100 cases, nearing 100 cases of hybrid coronary revascularization using Lima to LAD through robotics and putting stents in the other. That one trial has been done by NIH also. So this concept is just to, bring the best of the both strategies. But here in the CLI, when I have encountered few cases of CLI, critical limb ischemia cases. When I encounter CLI cases, the nightmare to me, because these are the cases with very, very severe comorbidities. Most of them will be with advanced atherosclerosis, CKD. You can't use much contrast also. And most of them are frail-looking elderly, long diabetic patients, CLI patients, critical limb ischemia. So such patients, when I always encounter like a patient I'm encountering with a cardiogenic shock, which is such a high mortality. Some of the cases, technically they are okay, but in the post-op, they will develop a lot of morbidities as well as even mortality is high. So we need to, as Dr. Astrid has given a very good approach, we need to have a approach which gives more survival benefit and reduce the morbidity. Like, when we do a long procedure with only surgery, doing the infrapopliteal with surgery, obviously the infection rate and other morbidities of the post-op complications will be very high. So such patients, obviously, we have to combine this kind of concept wherever the vessel is decent enough to have intervention, we need to do a iliac stenting or a femoral whenever there is a distal infrarenal part, and where we cannot have a good graftable decent vessel, we can do with a balloon just to tide over the crisis, to have a limb salvage, to reduce the morbidity, to improve the survival. So wonderful, wonderful talk. A lot of learning from his talk. Thank you.
Thank you. Thank you, sir.
Thank you, Dr. Damodaran. You have been very kind to us for being with us on a Sunday, spending a very precious time with us. Thank you very much. Now we'll go on to the last part of our program, a vote of thanks that will be delivered by Dr. Dilip, who has been working with us of cardiology. Over to Dr. Dilip.
No duty is more important than that. No duty is more important than that of returning thanks. A warm and gracious afternoon to our esteemed guests. It is my privilege to have been asked to propose the vote of thanks on this occasion. I, on behalf of the Saphire 2020 and the entire fraternity of the Cardiology Department of KS Hegde Medical Academy, and on my own behalf, extend my sincere gratitude to everyone present. At the outset, it is my honor to extend my heartfelt gratitude to our Honorable Chancellor, Sri N. Vinay Hegde. Respected Sir, I would like to thank you profusely for your highly valuable and unflinching support to the Department of Cardiology. We sincerely and immensely value it. I deem it a great honor to thank the esteemed dignitaries, Professor Dr. M. Shantaram Shetty, Pro-Chancellor, Sri N. Vishal Hegde, Pro-Chancellor Admin, who has delivered the keynote address this day. We are extremely grateful to you, Sir, for gracing this occasion with your inspiring words. Professor Dr. Satish Kumar Bandari, the Vice Chancellor, Professor Dr. M.S. Mudithaya, Pro-Vice Chancellor, Professor Dr. Alka Kulkarni, Registrar, Professor Dr. P.S. Prakash, Dean, Professor Dr. Jaiprakash Shetty, Vice Dean Admin, Professor Dr. Amrit M. Mirajkar, Vice Dean Academic. Thank you for your invaluable support to the Department of Cardiology. Your presence in this webinar has greatly enhanced its importance. I would like to extend my profound gratitude to Professor Dr. K. Subramaniam, Head of the Department of Cardiology, who is also the course director and the organizing chairman. He is the mastermind of the Saphire 2020 and has invested untiring efforts in making this event a grand success. Sir, thank you for your sincere and dedicated endeavors in this event and for also elevating the standards of our cardiology department to greater realms of proficiency over the years. I would like to extend my gratitude to Dr. Basuraj Utagi, Assistant Professor of Cardiology and the co-organizing secretary for this event, for your valuable cooperation and support. Let me now give my special thanks to the members of the organizing committee, Professor Dr. M. Gopal Krishnan, Head of the Department of Cardiothoracic Surgery, Dr. Naresh Chand Hegde, Consultant Cardiothoracic Surgeon, Dr. Manjunath Kamath, Chief Cardiac Anesthetist, and Dr. Raghav Sharma, Head of the Department of Medicine. I would also like to extend sincere gratitude on behalf of our department to Major Dr. Shivkumar Hiremat, the Medical Superintendent of the Justice KS Hegde Hospital, for his warm support in conducting this webinar. Thank you, sir. I now take this opportunity to express my deep gratitude on behalf of the Department of Cardiology to the distinguished course directors and speakers of today's webinar. Dr. B.C. Srinivas from Jayadeva Heart Institute, Bangalore. Thank you so for sharing your wealth of knowledge on overview of venous interventions. And you have proved to us that you are the master of venous interventions. Dr. Sanjay Malhotra from Narayana Hrudayalaya, Bangalore. Thank you, sir, for your insightful talk on current status of transcatheter aortic valve implantation.
Dr. J. Erilan from Madras Medical Mission, Chennai. We are pleased to have you once again for our second edition of Saphire, and thank you for giving an extensive talk on management complications of endovascular stent graft placement in thoracic and abdominal aortic aneurysms. Dr. Rajesh Vijayvargiya from PGMR, Chandigarh, thank you, sir, for enlightening us with this unique and novel talk on the role of imaging by OCT and IVUS in peripheral interventions. We also had some interesting cases and nightmares in peripheral interventions presented by the Kasturba Medical College Manipal team. Balloon everywhere, combined thoracic and abdominal aortic aneurysm presented by Dr. Tom Devasya, Head of the Department of Cardiology, Kasturba Medical College, Manipal. Thank you, sir. It was an interesting presentation and for being with us for our second edition, also despite your busy schedule. And nightmares in cardiac stenting by Dr. Sudhakar Rao and carotid stenting by Dr. Sudhakar Rao from KMC Manipal. It was really an interesting case. Thank you, sir. We also had Dr. Ashwal AJ from KMC Manipal, who gave a talk on hybrid interventions in critical lower limb ischemia. It was an innovative technique and case. Thank you, sir. We are so honored to have each one of you with us. Thank you sincerely for taking time off your busy schedule and for adding such immense value for our webinar. We are truly grateful to each of you, respected sirs, for adorning this occasion with such deep insights and with the wealth of your knowledge. Thank you, Dr. Damodaran, Senior Interventional Cardiologist from Apollo Hospital, Chennai, for moderating the sessions. You were one of the star speakers for our first edition Saphire 2019. So we would be honored to have you again as our course director and speaker for our future Saphire editions. Thank you, sir. Respected delegates, we appreciate your active participation in the Saphire 2020 with sincere gratitude. On behalf of the Cardiology Department of KS Hegde Medical Academy, I extend our profuse appreciation to each and every delegate for being with us today. I would like to extend a proficient sense of gratefulness to our postgraduates, Dr. Jenny Jacob, Dr. Srivatsa, and Dr. Ram Mohan, for holding the fort and for your immense support rendered in this webinar. A special gratitude to Dr. Jenny Jacob for anchoring this event with excellence. I would like to express my profound gratitude to Mr. Mahesh Chauta, the head of the IT department, for the overall technical support and for arranging this webinar and for volunteering to be present among us while sparing his valuable time today. Your efforts have significantly contributed to the success of this webinar. I would like to thank Ms. Savita for helping us with the brochures. Mr. Deepak Vetat, the head of Metronics, South India, responsible for the organizing and coordinating of webinar with the concerned course directors and speakers. We want to extend a heartfelt gratitude to you. You have been a driving force, not only this time, but also for our first edition. You have been a great support and have played a vital role in this webinar. Thank you so much. Heartfelt gratitude to Mrs. Vidya Jipai and Mrs. Pratika VN and Mr. Surendra, the secretaries of echo technician and the secretaries of cardiology department, for investing your time and dedicated efforts into this event apart from your departmental duties. We are grateful to you to have you here. Thank you, Mr. Ramakrishna, our university photographer, for your excellent work in this event. And a big thank you to Karunana and Yogeshana, the service assistants of our department, for your hard work and support. In closing, I would like to thank everyone who has directly and indirectly contributed to the overall success of Saphire 2020. By the grace of God, we look forward to further editions of the Saphire Cardiology Conference. We hope that we would be able to meet each other in person during the future events. Stay safe. Thank you.
Before we close our event, my special thanks to Dr. Dilip, who has been a big support for me in all aspects in the conducting this conference, for his behind the scene activities in coordinating the event and making it as a very grand successful. Thank you, Dr. Dilip. Yeah, I think we can end.